clarity on the consequences of non-compliance. Without an enforcement mechanism, bodies who do not comply with their safeguarding responsibilities risk undermining the very protections the bill is seeking to establish. And as regards terminology, and I know last week you met with Rays, and there was quite a discussion around terminology and what happens in Scotland and Wales and the need for it to be really clear. The definition of adult at risk and harm, they're broad, they're inclusive, and they reflect the lived experience of many of the adults who are enduring various forms of harm. But notably, and this is a bit of a standout for us that we found out in the safeguarding conference that we attended recently, was that the Scottish adult or protection experts would suggest that self-directed harm and neglect needs to be included in the definition. Interestingly, their figures show that self-directed harm and neglect accounts for 26% of their adult safeguarding cases, more so than physical harm. So this is an area that needs further scrutiny. You will also note in the submission that we have identified a number of issues which are particularly pertinent to older people in terms of consent and the need for independent advocacy. Many older people view professionals such as doctors, police or social workers, to name but a few, as authority figures, and in some scenarios might be reluctant to take to question their advice. So this could lead to older people complying rather than consenting, which we believe is especially concerning considering the powers of investigation proposed in the bill, such as interviews, medical examinations, access to records. We all know that independent advocacy is one of the most effective rights protecting provisions, and therefore an advocate should be appointed in every case where there is an adult facing safeguarding processes. Doing so would ensure that adults at risk who may feel intimidated, disempowered or unheard can participate fully in processes and challenge decisions made about them. Without this independent advocacy provision, which is outlined in the bill, older people may accept decisions without a full understanding of the implications. So in summary, our team at Company and myself wholeheartedly welcome the bill, as its provisions represent positive steps forward, protecting adults at risk in Northern Ireland in line with our counterparts in the UK. We believe some of the provisions need tightened to ensure older people's voices are heard, their preferences are considered and their rights upheld. We also must remind ourselves that older people are not and must not be passive recipients of care and protection. Rather, they are partners in shaping their care and protection. Also, because older people are not a homogenous group, the law must reflect this diversity and introduce intervention with them as collaborators rather than on them as subjects of that intervention. As a team, Company remains concerned a bit about the resourcing of the bill, because from our experience as with professionals, the phased implementation of the Mental Capacity Act has presented real challenges. We do not want to see that experience repeated here, though we do understand the Department's rationale behind introducing the bill, progressing it through the Assembly and then finding the budget. However, we really would like adults at risk to experience the positive impact from this bill as soon as possible. So just before we go to questions, I want to put in context why this legislation matters and why it is vital. Through our research, my team has carried out extensive reviews on offending against older people in areas such as crime, neglect and abuse. This evidence, supported by PSNI statistics, show that the physical and sexual abuse of older people is increasing, while crimes such as theft and burglary are luckily they're on the decline. The evidence also demonstrates a growing awareness about the dynamics of abuse, the dynamics of neglect and the dynamics of crime against older people, which preys on the vulnerability, dependency and diminished resources, together with a behind closed doors nature of offending. So this legislation offers a real opportunity for us all to be partners in safeguarding and protection of older adults against abuse. So I'd like to take this opportunity to thank the officials for their extensive and ongoing work required to get it to this stage. And Aimee and I are ready for your questions.
Okay, thank you. That has been useful. and the information that you've sent us has been useful. You just said you expect to deliver more detailed paper in December.
Yeah.
Okay. Suggested amendments to the bill, will that be included in it?
Well,
at any point when we have given reflection on the bill, we're trying to reflect on the basis of, on some occasions, recommendations, and in other areas, on food for thought, something that the drafters might want to give further consideration to, and of course something they may have already considered and disregarded. So it won't be a redrafted version of the bill, but it will look at the bill from our perspective and see where it would interact with the needs of older people.
Okay, thank you. And I mean, one of the things that you mentioned was the fact that the bill should include self-neglect and self-harm, and you give details of Scotland. I think you said 26%. Do we have any figures for what those figures would be here in the north?
Not at the minute.
Okay.
No, not at the minute.
But it's an important aspect that needs to be.
It was quite revelatory, I thought, that it's something that they themselves have found, further, because they're a bit further on down the road from us.
Okay. And I mean, I'm just going to fire a quick question. In terms of the independent advocacy, how do you envisage that to work?
In itself, I think it has to be independent, to be able to support older people, to make get the access to the support and understanding that they need, because a lot of times the people are they're trapped in their homes, they're trapped within family and domestic situations, and it's very hard for them to be able to negotiate their way through some of the trauma and the experience that they're going through. So having somebody there as an independent advocate to help, give their perspective, ensure that their wishes and their wishes and their needs are reflected is really important. Because as you know, sometimes, as we were saying about this illusory consent, that sometimes I just know what my mum was like, going into the doctors, whatever the doctor said, that was fine, they would and sometimes, we're going, but Mommy, we need this, or we need to do that, and it's not being reflected. So it's important that they have an independent voice there when they're, when they're not able to, present themselves. Is there anything you'd add to that, Aimee?
I suppose we just have to remember that anybody who is going to fall into the category of this legislation is going to be at probably the most vulnerable point in their lives. They are going to be incredibly vulnerable. The legislation applies to anybody over 18, but we're particularly interested in the older category in our own constituencies, which is over the age of 60. And if you imagine a 30-year-old and what support they might need when they're vulnerable, but if you imagine an 85-year-old who might have needed support irrespective of the vulnerabilities associated with the at-risk that they find themselves in at the moment, to be able to have someone to support them through really intrusive powers to help them understand the system. And if you look to the principles of the bill, and that desire, that requirement under the principles to ascertain wishes and feelings past and present, the only way to do that is to support that individual through independent advocacy. And also remember, this individual's entire support system could be the problem that brings them to the point of being at risk. It could be their family. They need someone independent of everything by their side to support them through that process. I think that's really essential.
Thank you. Just last question for me. That Adult Protection Board is obviously going to be important. Do you think that your office should be one of the organisations formally sitting on the board?
I think probably we would be best outside of it. Okay. I think at this stage.
Okay, fair enough. That's all from me. I'm just going to move around the committee. Linda.
Thank you for the presentation, Siobhan and Aimee. So just, I suppose, to go back to Philip's point around the amendments, I suppose I want to know what it would look like, or if the department have outlined to you why they're reticent to include that self-directed harm and neglect. Have they reasons for not wanting to?
I don't think we've had the conversation about that, but I think I think it's, as I was saying earlier, I think it's a revelatory thing that's come through, just from evidence from Scotland that are that bit further ahead. I'm not sure that they haven't deliberately included it, but it was something that we thought it was very pertinent that came up recently that we wanted to highlight.
Yeah, so it may be picked up even from today's meeting by officials, hopefully, but we can certainly raise that with them. I think it's really important that we do, given if it has that kind of incidence, like we were talking about.
I think the distinction between the bill in the Northern Irish draft versus perhaps the Scottish draft that we've used as an example is that the Northern Ireland, this particular bill requires the conduct of another person, and that's what takes it outside the category of self-directed harm. And I think the important point on that is it sort of brings the reader down a certain idea of what that at risk looks like. So you're imagining an individual, and you're imagining the conduct of another person, and it closes down the categories, I think, of harm. Whereas a more open-ended definition that doesn't require the conduct of another person, as per the Scottish system, might have a more inclusive look of what an individual at risk's lifestyle might be like, and the various elements of what might bring them to the point of being at risk. So I think it may be quite remiss to narrow the definition and reduce, the scope.
Two other quick things in terms of the advocacy, and I agree, because older people have a tendency to look at figures of authority and think, I have to comply here. It's what I've always done, and maybe we'll all probably get a bit more like that as we get older. So just how do we protect them in terms of who that advocate is? Or do you have any suggestions around that? Because the very person who's advocating for them could be the person who is the greatest danger to them in some cases.
I think the emphasis on independent is,
So an independent, there would be an independent advocate. Okay, so that would have to be very clear then. It couldn't just be an advocate of their choice, because again, they may just be complying with the person who says, I'll be your advocate. No, that's useful to know. And then just in terms of, obviously, older people are fearful, and you've outlined it in terms of that compliance and not wanting to be in trouble and not wanting any annoyance at their door. So is there anything specific that we can put into clause 5 to ensure that warrants are only used as a last resort? And how do we get that balance right? Because yes, they should be last resort, but we should never leave them so late that it's too late to protect that older person. It needs to be of value.
Yeah, I think it is about the intrusiveness of the intervention and understanding the implications of how that will, the impact more or less of that. You had something around that as well.
It's about necessity and proportionality. And I think that needs to be the backbone of everything that's done. And we have to remember that this bill isn't designed to remove all of the other safeguards that exist in a system. I imagine that this bill is for the most higher end safeguarding issues. There should be other nets to catch us along the way before we reach the crisis point of the powers that are outlined in this bill.
Yeah.
And if there's something you think needs to be on the face of the bill, or in guidance or training, then if you're sent a further report, then that would be useful to know, just to make sure that that balance is got right within the bill. We certainly don't want to leave it.
There's another point probably in terms of independent advocacy we'd like to stress as well, which is within the bill it is slightly ambiguous. And it's saying, we should have regard to as opposed to mandatory. And I think that's something that we would be advocating for as mandatory, advocacy, independent advocacy.
Well, it's tightened up.
Yeah.
Okay, fair enough.
That is an answer for me. No, that's brilliant. Thank you very much. Thank
Thanks,
you.
Linda.
Appreciate it. Thank you, Chair.
Danny?
Thank you, Chair, and thank you for your presentations. Obviously, there's going to be a lot of going through a lot of this. It's a very, very serious bill, and it exists because of your office, because of the previous work done by the previous Commissioner on Dunmurray Manor. So it is incredibly important that we are very tight on everything. I would just agree with Aimee. I've experienced as a nurse looking after older people, and they are incredibly vulnerable at that period in their lives. So we have to have every check and every protection, every level of protection put in there. You've suggested quite a lot of changes and quite a lot of things need to be strengthened. Would you be concerned that without these changes, this could be a missed opportunity?
I think it certainly will be a missed opportunity not to strengthen it when we've got the when we've done the review and we've had the consultation and we've considered. So yeah, I think it would be a missed opportunity not to include these these amendments, or just strengthen it to make sure the protections are strongly in place.
And you'll believe the bill without these without these terms being strengthened and the amendments that you've suggested, would adequately achieve what was envisaged by your office following the Dunmurry Manor scandal?
Any developments in adult protection will be welcomed. And I suppose we're sitting at a crossroads here where we've got a bill. It's a great bill. Mm-hmm. We're not intending to come here and criticising it. We're suggesting some fine tunes. Mm-hmm. So anything is better than the position that we're in at the minute, but we have opportunity to really drill down into it, particularly around that mandatory advocacy. As an organisation, if we were to pin down the most important things that we have highlighted in our advice, I would say it's the mandatory advocacy. We really need to look at that, because in the absence of legislative direction on that, it will become something that is optional, and this have regard to. And unfortunately, have regard to often falls to have we got the resources as opposed to is it a need. So it makes it optional, and that's a problem. Accountability. We've pointed out that we don't understand from the bill what happens if the bodies don't have this duty to report and cooperate. If they don't do that, we don't understand from the bill what the consequences of that will be. And again, as we mentioned earlier, this notion of self-directed harm. So those are three things I think that we would absolutely be disappointed to see a lack of development on.
In terms of engagement with the Department of Health, how have you felt that has went so far? Do you feel you've had enough engagement with them?
We've had a very strong relationship with them, and they've been very complimentary to you about the input from our team. I think there's just complete commitment from all sides, and shared purpose and getting this over the line.
And just in terms of clause 22, which is the guidance, what do you feel needs to be in clause 22 in order for this legislation to be successful?
I'm going to pass this one down. Amy's written the report.
Just let me remind myself what clause 22 specifically is.
Oh, you're going. Do you want to come back? Is that
Clause 22 was...
the guidance as it refers to... it needs to be clear. It needs to be concise. We need to know... we're looking at a bill in the absence of guidance at the moment, but even other aspects, if you look at the CCTV, which differs so heavily in the provisions to what the guidance will look like, and any guidance has to be clear, it has to be transparent, and it needs to be to the benefit of the person who is going to be subject to some of these orders, but actually for the frontline staff that are going to be trying to implement them and manage them. If the guidance isn't clear, then they're working in an ambiguous environment, adding stress to what they're trying to achieve. And we want consistency across the trusts. We want everyone on the same page. So I think that guidance needs to be incredibly clear and transparent.
And I think that, it's a position of the guidance and the training and that for staff, as this is an opportunity. It's not something that, this is to support staff as well as older people or adults, So I think the guidance has to be really clear. I think I came across from your discussions with the Belfast Trust last week and the RCN, about in terms of what's needed for them, and also the other discussions you had through with the Commissioner for... So I think, it really is... We have to get it right at the front end to avoid any mistakes, and it'll be less costly, as well. The economic value of getting the guidance right at the start is really important.
Thanks, Danny. Nuala?
Thank you very much for coming along. Today I remember meeting Eddie Lynch just as he commissioned the report into Dunmurry, and I have to say this is one case where a scandal and the kind of law that needs to come out to protect people because of it has moved quicker, and I know 2018-25 doesn't seem that fast, but we'll consider how slow we are at other things in Northern Ireland. For example, how long it took with Muckamore, hyponatremia. It is welcome to see this bill now. I have a few questions, just some new ones and some ongoing. Just if going back to the self-directed harm, with regards to that in under 18s, so we know it's not included in this bill for over 18s, and you said that in Scotland there's 26%. But is self-directed harm actually a matter for when it has to be reported or at risk for under 18s when it comes to those who are vulnerable in terms of either being looked after by the state or those with a learning disability? Something we see here, from families of loved ones who live in secure care at all. Is that?
We wouldn't be in a position to speak to the instances of under 18s. We're very focused on the over 60s, but I imagine it absolutely would, particularly in the circumstances that you describe, because they would be under the supervision of the social services system. So I could only suspect.
The reason I ask is because if it is, then there could be learning there as to why this could be included. So it isn't a brand new policy that the department would have to set, that there would be trusts that are actually obligated with it already. So I think it's worth.
I think the learning can absolutely be taken from Scotland, and when we say the 26%, that's the highest instance. So the physical harm at 22% is the second. So it is the highest instance of the use of the protection, and I think it's quite a comparable jurisdiction.
It is, indeed. It's something definitely worth scoping out, hopefully, from the department rather than the committee. The next question then was around the advocate. Who do you think could be an independent advocate? We have had, the trade union that represents social workers in front of the committee. I met them privately a number of times, and we do have issues with vacancies, but also what's actually required in social work. And adult social workers are often under pressure, and they're often in any emergency departments quite a lot as well. But do you think it's a social worker that would be an independent advocate, or is there an opportunity for someone else to actually fulfill that role, so that it's not just kind of creating another problem shared rather than solving it?
I think in this situation it wouldn't be about whether the person was a social worker or not. It wouldn't be a social worker dealing with them in the system. So it wouldn't be another requirement of the health and social care system as it currently exists. It might be a separate, because the whole point of the independent aspect of the advocacy would be that the individual wouldn't have any input into that person's care at that given time. So it could be a social worker, but they wouldn't be employed by the trust.
It's but it not. I support this idea. I think it would be very helpful. But if it was a social worker, there's still vacancies in social work, not just within trusts, but also in the independent sector too. And we know that some will move from trusts to independent sector, so it will still create a flow problem. So can it be a multi-skilled role? And options, kind of like what Ray Jones had said when it comes to children's care and children's homes, for example. Could it be a multi-skilled or different option?
I got the impression from the lady who was talking about the resource and the costing that would be something that would be within the teams, that you could be, different professions can be, or different sort of professions can be an independent advocate if they're trained up. It's all about the training.
If you imagine, even from our own office, we have a team of independent advocates. I'm an advocate and I'm not a social worker. So there could be a wide range of suitable individuals that could go forward. It could be a situation where individuals are specifically trained and they don't have to have any specific qualification in the background. It's something that has to be ironed out by the powers that be, I would imagine.
Okay. Well, that's really helpful, actually, just to know that it's not nailed to one specific profession. I want to talk as well about serious case reviews. We haven't really touched on it yet with in committee, but you mentioned a little bit about serious case reviews and whenever the need for it comes into play. But what would you, and I'm sure it'll be hard to describe, but in what instance do you think that a serious case review actually will be needed? And in terms of the criteria, because we often have people in front, the reason I ask, we often have people in front of us as reps around the issues of serious adverse incidents, for example. So it's trying not to create another similar system that has major problems, but actually serious case reviews that work. So how do you envisage that it would work well?
First of all, to say we really welcomed that serious case reviews were being put onto a statutory footing, and we're glad to see that they must happen as opposed to they may happen. We did, of course, note that the bill is entirely silent on what that will look like in terms of what will trigger it, whether it would be published, whether there would be any follow-up, monitor and recommendation. That all has to be clarified. And I think the Human Rights Commission had made some recommendations in that regard around the procedural standards, and we'd entirely endorse their position on that. I suspect what will trigger it would have to be, in the name, serious cases where there is an opportunity for learning and where the system has gone wrong. I can't imagine it could be too much different from the serious adverse incidents that you've described, and that system's under review, and that's perhaps something for the legislative drafters to look at to see how those two systems will run in tandem. I think that would be really important for them to consider how they will interact and when one will be triggered as opposed to the other.
Yeah, and we're often, the reason I ask is we are often discussing how serious adverse incidents aren't actually getting the closure or answers and issues. So it's about, if we're creating something new, how do we make it work? And what you're talking about in terms of the criteria, how it's triggered, whether it's be published, where is it best to actually stipulate that? Is that on the face of a bill or in regulations or in guidance? How do we do that?
Yeah, I think that it needs to be stipulated within the bill, and then so that the guidance can be underpinning that then, you know. So I think that's what came out too when the Human Rights Commissioner was talking about different things. It was about, I think it was about the CCTV last week, that, you know, that things need to be specified within the bill, and then the guidance will follow, so that there's no sort of misinterpretation across, you know, different bodies or trusts or that kind of thing.
Thank you. Bringing on to my last question is about CCTV.
I know, we were waiting on it.
And I understand the difficulties that people have with it, but you know, it is important when you speak to people, they ask, oh, is there CCTV in that? And it's because of high profile cases. So can you tell us a little bit about where that you stand on CCTV, how you think it could possibly work if you do support the use of it?
I think it's about consent and dignity and proportionality, you know, and I think that's what's sort of been coming across, is that, you know, I think if you went around this room, you'd have various, you know, varied kind of opinions on whether it's right or whether it's wrong, and then you've got the whole question of, like, how it's enacted, and, you know, who has access to it, and how, I mean, we talked about you talked about GDPR last week, and the, you know, would we all like to be sitting in a care room home talking to our loved ones, knowing that your conversation is being either recorded or, you know, being watched, or who would have access to those type of things? So it is very kind of, consent must be meaningful, you know. We have to actually make sure that that it's in there, and then that it's proportionate. B, that the guidelines around it and how it's enacted, how it's, you know, how it is managed, are really, really clear, because it is something that, you know, it just needs to be targeted and proportionate, and a really good reason for using it. And I think you'll find that some people will want that and some people will not. But the option to have it in the bill is, I think, would be quite important, you know, to have the I mean, when we were listening to the Human Rights Commissioner last week, and I think that, you know, all of the guidance and the understanding was the PSNI have in all of this, and how their implementation and, you know, of it in other areas is going to be key, and the learnings are going to be key from those people who know about these things. Go ahead, you want to?
I would just say that the Department of Health acknowledges that a care home is first and foremost someone's home, and from that principle everything else has to stem. So we have to remember, when we think of these facilities that CCTV would most typically be placed, that we have to think of that from the position of this is the individual's home, and we can't take a paternalistic view to look at, we know what's best for a category of people just because they reach a certain age, and we have to look at them not as one group, but as a group of individuals. Some will have capacity, some will not. Some will want the CCTV because they prioritise the safety and the reassurance that will come with that. Some will prioritise their dignity and find that quite distressing. So I think it's important that we have a piece of legislation that is really reflective of diverse views, and it has to be able to meet the needs of all individuals in our societies, and the views and the wants, the wishes of those. So I don't think that we could sit here and assume to know what a group of older people would want in the scenario that they find themselves. And we've heard some really terrible situations where CCTV, like Muckamore, has provided an absolute lifeline in terms of prosecution. But we can't take the individual out of the scenario and not appreciate what one person would want. And I think from Copney's point of view, we're very concerned that some organisations will be very pro CCTV and they will want it, and because they will say, well, I've nothing to hide, so put the CCTV in. Others will not want it, and the supply and demand availability of placements in Northern Ireland is so it's so challenging as it is. And what we would hate to see is that there's one facility saying we are CCTV, so if you want to come here you have to consent to that, or we're not, so if you want CCTV you can't come here. I think that's a really important nuanced point, that it cannot be used as something to narrow or put barriers in front of opportunities for appropriate placements for individuals in Northern Ireland.
And not to go down another rabbit hole, but CCTV is not the only way of protecting people in situ. Obviously, there's a lot of the abuses happening outside of sort of care settings and that, so you can't have it in people's homes. But if you look at technology and able care, if you look at the use of sensors and monitoring and stuff in homes, it's all coming. It's all being tested, and very much it has been sort of piloted and up in Coleraine and that through work with 3Age NI that we did last year. There's a lot of things that can be done in order to ensure safety within care settings and monitoring that's not necessarily all down to CCTV, but that's a whole other discussion.
Thank you very much. I think that's been really helpful. As someone who has been vocal about the support of having CCTV in some way, it is important for me and all of us to remember that it is complex, and so thank you.
And would we like it? Would we like it ourselves? Sometimes it's getting the balance right.
Thank you very much. I'm sure we'll have more questions in December.
Thanks, Nola. Diane?
Thank you, Chair. And thank you for the presentation. Like Nola, I think that is very helpful in relation to CCTV. I think it's probably one of the more vexatious issues in the bill, and working it out so that it provides protection but not intrusion is going to be... I haven't seen a pathway for it yet, and I think that will be very important. I can understand if your loved one has been in a care setting and have had a dreadful experience in that setting. I can understand why you might say, I want this, but everyone is an individual. Everyone is entitled to their privacy and dignity, and we must be very careful that whatever is in this bill respects that and so on. So that is really, really helpful, and sometimes draws us just a little bit back from where we think that might have gone to. So thank you, that's important. I'm just asking a general question, because this has arisen as a constituency case. So and I think it's important just to get a view. So there's a lot in the bill about the responsibilities and so on of people, protecting people and all of that. But one of the things that we find it difficult is to get accurate information from trusts and authorities whenever a complaint has been made, and information that actually gives the family an idea of why that complaint has been made, etc., etc. Have you a comment on that issue?
A comment on whether what's happening.
Why do trusts not comply with access information requests in a timely manner, etc.? I mean, because I think that there is a duty on care homes, there is a duty on families. Where's the duty on trusts to make sure that they're responding to safeguarding issues?
I suppose if the question is around when the complaint has already been submitted to the trust and the release of information that comes back.
There's access information.
I suppose there's data protection issues and there's other complicating factors that I am sure puts pressure on the trust. We also have a system now that encourages complaints, so they're, I imagine, to play devil's advocate, entirely bombarded. But the problem behind all of this is poor communication, and then it's compounded by poor communication. I think that's the point that maybe you're making, that families feel...
It is, but I also think that there should be some compelling reason why trusts can just simply ignore access information requests, etc., etc.
Well, they can't. That
well,
is the
I know they
crux of
can't,
it.
but
Yeah.
they do.
And I think in those situations there should be a complaint made to the Information Commissioner's Office. There's organisations like ourselves that have advocacy teams, so if constituents are finding difficulty in managing the complaints process, we are willing and able to assist, and we will help them navigate that, and we will prompt the trust and break down the communication barriers. The Patient Client Council, they also offer support. So I think it's about seeking additional support if that is happening to free up the system. The other point is that the Public Service Ombudsman, they will take complaints directly without a response. So if a response is not received and not forthcoming in respect of a complaint, the complainant can go straight to the Ombudsman, but we would be happy to support them through the next stages that they can take. But there are obligations under the Information Commissioner's Office around official freedom of information requests, subject access requests. I imagine sometimes it's a bit tricky because the person who is making the request is not the person whose data it belongs to, and that may be a complicating factor. But in general terms, I hope that answers maybe some of your question.
Gives me some pointers.
Yeah.
Thank you.
I'm happy to speak to you about that separately if that helps.
Interesting thing about constituency work is that all kinds of things happen in a week.
Sometimes we do. Sometimes we get queries from constituencies, so if there's ever anything we can help with, we're happy to.
Thank you, Jen. Orlia?
Thank you, Chair, and thanks very much for your presentation and all of your answers you've provided so far. I just wanted to touch on, it's maybe bringing it back to the issue around the self-inflicted harm, and maybe some of the potential gaps that are in the legislation. And for maybe your response, you mightn't have had a chance to look over the NISRA stats that were released just today. But for the amount of suicides that have taken place in the year 2024, but they've actually shown that there's been a 30% increase, so 221 deaths in 2023, and the deaths recorded for 2024 is 290. So I'm conscious that it's important to say that there might be some specific reasons, there might be deaths that have occurred in previous years, and due to the work from the coroner's office, they've just been picked up and recorded in 2024. It's important to state that. But I think that one of the glaring issues and worries for me in those statistics is the rise in deaths in over 60s. So in that particular year in 2024, according to the numbers, it's actually 1 in 5 of those deaths have been deaths by suicide in people over 60. So I know that the CMO has released a letter this morning on it, and he's calling for, saying that there's obviously a clear need for further support and research into trying to work out why we are seeing this rise. So obviously it's all interlinked to the conversations that we're having today around safeguarding, and just particular points that you raised around the self-inflicted harm. So maybe just some of your feedback or thoughts on that would be much appreciated.
You want me to take it? First of all, I wasn't aware of those statistics, and that's really interesting and really concerning to hear, actually, the statistics in relation to over 60s. I think, in respect of what you said, it's absolutely relevant, but I think that, and it's relevant across the board, we don't want to narrow any of the application of this bill. We want, when given this one opportunity, that this bill gets the broadest catchment as possible. And so there's no reason why we wouldn't, particularly when we can look to other jurisdictions that have had their adult protection legislation up and running for 10 years, and that part of it has been so prevalent. So I think with that in mind, and also in terms of making it as beneficial and as wide-reaching as possible, we would absolutely hope that is an aspect of our advice that will be taken on board.
No, thank you for that. And sorry, because I'm just conscious, I know that they were only released this morning, so I didn't mean to put you on the spot in any way. And I'm sure you'll go away and have take a closer look at the NISRA reports following today, and maybe that'll factor into your additional report that we're going to receive in December. So thanks very much for all of the work that you are doing.
Just love to come back on that, Orla. If you look at it, it'd be interesting to see what the gender breakdown is on that as well, because that's some work that I've done before, and it's, if you're looking at, and it speaks to the whole sort of mental health services for people over 65 and access to that, that there's kind of a drop off, and it's not, there's not been as much support around that or development and that as would have been wanted from, with the mental health strategy. So I think we when you look at sort of the rates of suicide in Northern Ireland, the gender split as well in terms of the over 60, or it's quite significant. When I worked at AGNI, we did a whole thing around men's health and the Good Vibrations programme, and because we looked at sort of the levels of alcoholism and addiction and in Northern Ireland compared to other areas. So I think it's a wider discussion, which really will reflect on the adult protection longer term, but it's a wider discussion around mental health support for people over 60.
Yep, no, absolutely, and I would really appreciate, even following today's meeting, we can take this conversation offline, just to get some more another chat about it. But thanks very much.
Thank you.
Thank you, Amelia. Alan?
Thanks, Chair, and thanks, Siobhan and Aimee. You've been very helpful in terms of clause 26, the role of independent advocates. You've expanded upon that to the committee members, but I'm just keen to know just your thoughts further on that, about who you believe would be responsible for the training of those independent advocates and the monitoring thereof.
I suppose it would have to be looked at on where the funding is going to come from. Organisations can be independent despite being funded by a certain department. So the association with the department or the responsibility of a department won't necessarily impact its independence. So it may be something that falls under. I think this is a joint project between the Department of Health and the Department of Justice. I'd be wrong in that. Maybe something you need to.
But when you think about all the bodies that we're talking about here, in terms of the police, the PSNI, the public health, all the bodies that are involved, and this is not just the health and social care trusts and what's happening in the community, where the independent advocates sit, whether they sit, we were chatting about within departments or with externally, I think regardless of who does the training, it's what's in the training that's consistent across all of these things would be really important. But I'm think it just depends on what's there, because I was saying the abuse happens everywhere, and so it will rely on different bodies to respond to that and then appoint the independent advocates, I would think. So it's not clear yet.
Just when you talk about funding, then that maybe would lead me on to another question. I've expressed my own personal frustration and fear that this bill may not get the justice that it absolutely deserves, and that fear is that we will not see the annual funding that it maybe requires and necessitates. And I suppose that leads me on then, given that this and the reports from Home Truths date back to June 2018, back to the Eddie Lynch days. How frustrated have you been, Siobhan, at the pace from where we were then to where we are now?
I think I'm 7 months in the job, so from my experience in talking to the team and what's been going on is just the the good relationships. I've met with the Department of Health as well. There's been really the sort of communication. So that's my experience, is that the people are working well together, and we're all delighted to see it forward. I haven't really had the experience of how frustrating it's been to get to this. Have you, Aimee? Because you're.
What I would say is that safeguarding Home Trust didn't identify a gap in safeguarding, and then we just stopped until we got here. There has been massive changes in the system itself, and this is culminating now with the introduction of this bill. So we have seen real changes in awareness. People are more aware what safeguarding looks like, what people who are at risk look like, inspections through the RQIA, those things, visibility around abuse and awareness of abuse, all of that work is happening still in the background. So absolutely, would we have wanted it more quickly? Of course we would. We would like it finalised now and up and running and fully funded and fully implemented. But there are other aspects of the system that have been making progress in spite of the lack of legislation.
I mean, if you think about the safeguarding conference we were at, and in the Southern Trust, and the extent of the work, and what there's been this. I think safeguarding it's really endemic across all organisations. There's a lot of work. There's a lot of people very committed to it and moving it along. So I think that. It's not just the legislation, it's about the whole infrastructure behind it. And my experience of it is that, I've been very impressed by certainly the teams in the trust, some of the work that they're doing and the interaction that we've had with them. But it's such a big area, and it's such a serious, it's growing. I mean, I think it's the actual, I was just looking at the stats, the number of safeguarding referrals, over the last 5 years has grown from 4,800 to 8,600. Now, is that because there's more issues, or is that because there's more awareness? And I think that's where there's not sort of clarity. We're not sure what that is, at the minute, but it's, so it's growing. So the cases are going. So it's a big industry.
Very helpful.
Linda, you wanted back in for a quick point?
Just a very, very quick point, and you just kind of touched on it there, Siobhan, when you talked about the infrastructure and the importance of all that is going on behind the legislation. Just something that on a separate conversation around the duty of candour. I mean, it touches on that CCTV stuff as well, and would the duty of candour actually make a real difference, because there were people who knew about abuse going on, whether it was with elderly or whether it was in Muckamore. There were people who knew things. Do you think that statutory duty of candour would be helpful in terms of that infrastructure?
Or is Aimee answer that?
I think absolutely. It definitely would. A duty of candour can only help, and it's all about the culture. And I know the Department of Health are doing a lot of work, even with the RQIA and their joint Being Human framework. And what strikes me is that there's loads of parts of the puzzle that are coming together with the same vein, which is to be more open, to be more transparent, to encourage openness so that individuals aren't afraid. And I think that's a point maybe that we haven't touched on today, is around that openness and people not being afraid. We've spoken to some of the organisations and individuals that would be responsible for this duty to report and duty to cooperate, and they're afraid. They don't know what's going to be expected of them and whether they'll get in trouble if they don't understand how to do it right. So that part is going to be as important as getting the wording in this bill right, how we roll it out, how we get buy-in, because people need to buy into this bill and see that this is an opportunity to safeguard the most vulnerable in our society and set the culture of what we will accept as a society and what we will criminalise if it's not adhered to. And if people are afraid and they think that it's another requirement of them in a pressured system or another stick to beat them with, they're not going to see that what we're trying to achieve by this bill is a shift from responsibility on the vulnerable individual at the centre of it to the system. We want to take that pressure of someone being responsible for their own protection, to let us take that pressure off you, let the system catch you and protect you. So I think that all of that feeds into where we want to be as a system, the culture that we want to have in our across the board in our health and social care. We want people to be open, we want there to be a duty of candour, but we want them to feel that they're safe to have that duty of candour. So it all plays together.
And the people see it as an opportunity to do things better together.
Oh, absolutely. Thank you, Chair.
Okay. Aimee, thank you very much. That has been very, very useful. The comments that you've given us and the information that you've given us will certainly, hopefully, put to good use. So thank you very much.
I love the report.
Okay, members, so we're moving then just directly on to the next item on the agenda, which is an oral briefing from the Minister on shift left agenda. So can I refer everybody to papers at tab 6, page 51. That includes the clerk's memo at page 52. We've also received presentation slides at page 2 of our table papers. So we'll just await them. Okay, so can I just welcome the Minister, Gearóid Cassidy, Director of Primary Care within the Department, and Professor Cathy Harrison, Chief Pharmaceutical Officer. You're all very welcome. So I'm, Minister, going to hand over to yourself or whoever for some introductory remarks.
I think Cathy and Gearóid will talk you through the kind of bones of the neighbourhood scheme, but just a couple of minutes for opening remarks by my chair. I think since I took up post, I've made it my business to get out and about. I've visited now quite a significant number of health and social care facilities. I have listened to the workforce, be that social care workers, social workers, nurses, GPs, consultants, surgeons, administrators. And there's a universal desire for change, a universal recognition that if we simply continue doing what we're doing, we are hurtling towards some form of collapse. And the change has to be this almost fabled shift left, where I know that this winter we will inevitably be looking at our acute hospitals and the queue of sick people waiting to be treated. We have to shift left and try and think about prevention, in other words, keeping healthy people healthy. And when people do begin to get sick, getting in early with early prevention. And the neighbourhood model is the way to go. And it's not just about general practice, it is also about community pharmacists, it's about dentists, it's about ophthalmology services, the 4 pillars of primary care. But beyond that, it's also about local government, it is about community, voluntary and social enterprise groups. It is a comprehensive set of involvements. But GPs are central. And without GPs, it cannot be done. So to bring you up to date with where we are with the GPs, I wrote to their GP committee last week. I have had a response as of yesterday. And I am now reasonably optimistic that we have the opportunity for a 3-phased approach to resolving difference. The first will be the NIGPC. The committee will be engaging in short order with officials, seeking clarity on the latest offer that they have received from us. Phase 2, they will take that back to their committee, and if things go well, then we will open a new round of negotiations and discussions on a new contract. A couple other points if I may, Chair, which I think are topical and maybe of interest to you and your committee. A small number of GPs have been talking about a hybrid model. To be clear, a hybrid model means some people pay for accessing their general practice. Not on my watch. The tenet of the National Health Service, it is free at the point of need. I am not moving off that. I don't think it's a universal view. I don't think it's anything near a universal view, by the way, within primary care. Also, probably the toughest decision I've made in 18 months was to go back on my promise of introducing the real living wage to social care workers on the 1st of September. And I would just ask the committee to accept that that is a sign of just how desperate the finances are and how big the gap is between what we have and what we need. Since I've made the announcement, officials are telling me that actually within the sector, and we know this through monitoring and surveying, the majority of staff, who of course are not employed by us, are employed by care homes, are already earning on or above the real living wage. But that's of no comfort to the minority who are below that. And I think the final thing I want to say is on that funding gap. You know, the executive are promising up to 100 million towards pay. This will leave us with a gap on pay of at least 109 or 108.7, I think is the exact figure. And beyond that, we still have pressures amounting currently to 91 million, which we're still trying to drive down. But it still leaves us in a very precarious position with regard to next year's budget. And in terms of the waiting list initiative, it wasn't 125, it was up to 125 in 3 pots. 85 million for red flag and urgent. And that was not new money that the executive gave us. They ring-fenced 85 million in our baseline budget. 80 million for capacity building so that effectively in future we're less reliant on the independent sector. That was not new money, again, that was ring-fenced by the executive out of our baseline. And 50 million of new money to address waiting lists, particularly long waiters. And that was new money. And it's being spent, and the 85 million is being spent, but the majority of the 80 million, sadly, needs to be put against the deficit within our budget. So that's broadly, I think, the sort of headlines, Chair. I will now ask Cathy and Gearóid to talk you through the kind of framework of this neighbourhood model. All I would say is my ambition is that we get everybody involved onto the starting line for the 1st of April 2026. But after we fire the starting gun, for some it will be the equivalent of a 100-metre dash to get to the finish line. Others will be doing a 5k or maybe even a 10k, so we'll not all get there in one go.
Thank you, Minister. I'm going to just talk a little bit about the neighbourhood model for Northern Ireland that we've just started to develop, and the commitment to developing a neighbourhood model came in the reset plan that was published this year in July. And I will read it out because I think it is helpful just to frame what we've been asked to do. But the commitment that was in the Health and Social Care Reset Plan said that by March 2026, working with partners, we will have developed a new neighbourhood model for primary, community and social care, which will deliver greater levels of care for citizens, including children and families in their communities, alongside a funding plan for support delivery from April 2026. This model will see community pharmacy, GPs and their federations, voluntary and community organisations, trusts, independent providers and other statutory bodies and local government working closely together in formal partnership to provide integrated care. And just to tease out exactly the key things from that, and that we are looking to describe a neighbourhood model with an associated funding model that could support its development and by the end of March next year, to allow the beginning of the development of a neighbourhood health in Northern Ireland through this. And as Minister said, that will be, and our ambition is that the system can start to move, that it isn't pilots in certain areas, that we are starting to see system change, but recognising, and as I go into it, you'll see there'll be parts of our system will be ready to move much quicker than others. But to develop it, Gearóid and I are working on this together to co-lead, and we've split the work up into sort of 3 phases. And at the moment we're in the design phase, and that has meant that since sort of the end of the summer and right up until the end of this calendar year, we have spent time speaking to stakeholders within the system. We have spent time looking at models from other countries, and also meeting with stakeholders and on visits out into our system to meet with different community and voluntary groups, but also service providers, including general practice. And in this phase, what we're aiming for is that we can articulate a vision around neighbourhood health, along with some underpinning principles that would support that to grow. We also, in this period, are looking for examples of neighbourhood health that are already happening in Northern Ireland. And we've launched a call for evidence on the 8th of October, and it's open until the 25th of November. We extended it by request for another week. It's on Citizen Space, and already we've had over 80 responses from that, and we're really pleased that it's confirmed what we thought, that there's already a lot of really excellent work. So in that design phase, this is all about listening, and this is where we are now at the moment. At this stage, we have deliberately not rushed towards solutions and a favoured model at this stage, because it is about listening and genuinely trying to understand what we will need in Northern Ireland. From January next year, we're moving into what we're calling build, and that's going to be, we're going to have to put a little bit more detail around this in terms of what this could look like, how our health and social care system is going to adapt to work in a more neighbourhood model of health and social care, and also how we will work with the partners that Minister has indicated, including, very importantly, our voluntary community and social enterprise partners. And that would allow us, bring us up to April 2026 to commence a programme, and to have already in that to thought through how we will. It really is a growth programme, so it is something that will take us into the future. Okay. One of the things that we have seen in our research of neighbourhood models in other parts of the world and across the UK as well are that they didn't happen overnight. Okay, and they certainly didn't happen in 6 months here. So just to reassure everyone, we're not going to have a full-blown neighbourhood model by April. We will be at the beginning of a journey, and it'll be a journey of change and growth in how we do things. Some of the examples that we have seen have really demonstrated that, and maybe some mature international examples like Nuka in Alaska that took 30 years to develop, but also some closer to home examples from like Wigan and Manchester, and that have, are really 10 to 15 years in development. So why are we doing this? We are doing this because we have a very complex system of health and social care, and also with voluntary and community sector involvement in health. But our current practice is frequently siloed, and a lot of our focus is dealing with demand and in our hospital settings. And the main sources of our service pressures, as you know, are demographics, so like age and our ageing population, but also our socioeconomic aspects of that. But also we have specific challenges in terms of rurality as well, and also our health behaviours don't help, and also budget and resources on a long-term basis do not help. So they're our main sources of service pressure, and they have an impact on our service users. And that is impacting at the moment on access to healthcare services. We know that there is dissatisfaction among service users around access to, for example, GP appointments, and also reliable access to care for long-term conditions, etc. That's also manifesting in terms of service user experience in increased waiting lists, poorer health outcomes, unfortunately, and very much fragmented care and low patient satisfaction, and I would say also maybe perhaps lower trust in services as well and access to them. And it's not only having an impact on service users, it's having an impact on service providers in terms of workforce satisfaction, but on also highly complex models of working with multiple different agencies that cause increased costs, duplication, inefficiency in the system, and also challenges now with communication, data sharing, etc., and increased administration, questioning really sustainability. So one of the things that we have been doing in the last few months is really challenging ourselves and with our stakeholder engagement to say, what do we actually need from a neighbourhood model in Northern Ireland? What if we are going to embark on this, what will be the functions of that new neighbourhood model, and what will it bring? And just in terms of a neighbourhood model, what we are talking about really is, I suppose, at a more grassroots level and at a local level, service providers working together and sort of provide and support a system that supports different services who are currently working perhaps at best alongside one another, maybe overlapping, to work more collaboratively together. And it is an inclusive model that includes providers from primary care, also from our community trust-led services, and also our voluntary and community sector and social care providers, because they are all of the providers that are already in our local neighbourhoods. And the model will enable them to work together to focus on both the delivery of care, but also on improving and working together to improve health and well-being. And in terms of the purpose of the neighbourhood model and what we would like to see the model supporting, it's really about collaboration, first and foremost, and it's allowing providers to come together to collaborate and agree on, at the heart of it will be on the consistent delivery of very core functions that matter to the people who live in the community. And again, will be no surprise, the sorts of things that we're hearing on that are that is reliable access to a GP if you feel you need it for an acute health need, but also reliable and well understood access to care for your long-term conditions that actually are more coherent and make sense to you as a person living in that neighbourhood. And in addition to that, more space and time and more focus on prevention and proactive care to avoid the huge demands that are being placed on our acute services. The second area that's emerging that we would like to see from a neighbourhood model in Northern Ireland is also that those provider alliances would be able to collaborate with health and social care trusts and to offer their population more access to more advanced and specialist care and services closer to home. So truly enabling shift left by working together at that provider level and supporting that. And also that those provider alliances, we also need to see a model that will support them to strengthen and build their alliances over time, and to do that by responding to opportunities for their population, such as commission of new services, invest to save, etc. And finally, we also need from the neighbourhood model to allow our provider alliances within health and social care to connect with wider public services in terms of tackling the wider determinants of health. And this is where there'll be links with, for example, housing, poverty, etc., that are not the domain of health, but they are the domain of our other departments. Some of the benefits of the neighbourhood model that we would like to see are the improved health outcomes, reliable access to same-day urgent care, and improved continuity for complex care. A focus on preventative health care that the system struggles to have at the moment, with earlier detection of disease. Also, some outputs like higher uptake of vaccination and screening programmes, and also reduced unplanned admissions to hospital and reduced attendances at ED and out of hours. We would like to see that this would be a model that would bring more trust and more greater patient and carer satisfaction, where people feel listened to and receive care that's coordinated, and that there would be more care delivered in the community rather than all in our secondary care services. With more care also provided in ours by using all of our available services. That we believe would lead to more efficient and sustainable use of the resources that we're using at the moment, with less duplication, fewer gaps in care, better value for money, and also stronger community resilience, where we have empowered communities and individuals within our neighbourhoods who are engaged and able to be engaged more in their own health, with more holistic approaches to tackling health inequalities. And also even potentially getting into tackling issues such as supporting local workforce and supporting people back into employment and catalysing economic regeneration. So, like in summary, really, the main benefit, I suppose the key benefit here is beyond health and it is into well-being as well as health. our thinking at the moment is in terms of the neighbourhood model. I said at the start we've been tasked with describing what a neighbourhood model would look like, and for that we are going to have to think about like an operating model for health and social care to start to be able to work in this way with our partners, and also an associated funding model. So I'll share with you where we are at the moment in this, and I have to say we are in the design phase, so we've been sharing our thoughts with stakeholders, and they've certainly told us what they think, so we can get into that as well. But at the moment in our health and social care system, we don't really have a system that allows providers to really come together in this way, particularly at a more local level. And so we do need to think about what intervention we may need to place in terms of in the system. And one of the proposals that we've been testing with our stakeholders is that we could build a model, for example, around what we're calling integrated neighbourhood teams, and they would be teams really of people who would come together, but they represent wider and bigger teams within the wider community. And those teams of teams would come together under an ethos of joint leadership, because I think that is important from the beginning to say. They would operate within the trust or AIPB footprints, which are the same. And we're testing the idea of working at a population level of around 115,000 people, which is at our GP Federation footprint level, because that is a strata that we have in our system. That these integrated neighbourhood teams would act as the core component of the provider alliances and help to bring together those currently siloed professional teams and organisations, and also link with voluntary and community sector. Importantly, that they would really fully understand the populations that they serve. They would have a high level of connectivity to those populations, and they would work together in a team of teams to drive the delivery of those core functions and also the priorities for moving care closer to home as those evolve. And that those integrated neighbourhood teams, if they worked at that level of around 100,000 people, but that would involve working with smaller neighbourhood groups that would be within that footprint. And they are the natural communities where people already say that they feel they belong. And I can just say that's really become apparent to us in this work, is that we do not need to disrupt that natural communities that they're so rich in. And Gearóid and I have had the opportunity to go out and visit a number of different communities, and I think that is something we do not want to disrupt, we want to enhance, definitely. Moving on to funding, the funding model for this really, we're seeing it as, first of all, a lot of this is about mobilising what we're already doing and helping people to work together better and help people to work and collaborate better. So certainly what we're seeing here is we're calling it a mixed funding model, but very much involves mobilising existing funding, but also allows maybe a more proactive approach than we've had before to invest to save initiatives, but also looking at opportunities from outside our normal traditional health sources to accelerate improvement and growth. And we see that happening over 4 different levels, I suppose. First of all, we do see that there will be a need to identify some funding from the beginning, from within our HSC budgets, to support whatever we use, if it's integrated neighbourhood teams, what are that, just to come together and to really start to begin to focus on collaborating and using their existing services really around working to reduce and manage demand within their services. The second area that we see is that using money from within HSC budgets to what we're calling invest to shift. Because to shift left, that means shifting clinical care and responsibility from one part of the system into another, and resource does need to follow that, but we are not in a position where we can double fund. So we do need to have a model that recognises that actually this is a very highly collaborative model, which would be between the trusts and the provider alliances, to say if we're going to shift activity, the resources will also go, but it does mean that that activity will have to stop at a point in time then in the trusts, for example. So that we're calling that invest to shift. Other elements of funding, I think the provider alliances themselves will, because of the nature of the work that they do, I'm confident, identify opportunities for invest to save themselves, and that we as a system need to support that and have mechanisms in place that if money is saved in a part of that system, that it can be reinvested within that neighbourhood, and the provider alliance can have some purchase over how that is done. And finally, that those provider alliances would be encouraged and supported to attract other funding from other sources that does become available for us from time to time. And that money could be from, for example, social finance models. It could be from innovation, research and other investment opportunities. And I just have to say that, again, in our engagement with stakeholders, I have to say, like, our voluntary and community sector are experts in some of these skills in relation to accessing funding and using it to sustain really tremendous work and growth within their communities, to serve their communities. And just final thing I wanted to say was that, you know, I did today. I actually drove up from North Fermanagh. I was in Ederney. And I had the opportunity to visit Ederney Community Trust. I told them I'd give them a wee shout out because I had to leave them early to get up here. But what I saw there and what Gearóid and I have seen elsewhere in Northern Ireland does give me some confidence that actually that we do need to change. We do need to change what we're doing, and already communities like the Ederney Community Trust are coming together, really understanding their community, really tailoring what their services that they're providing, and we're already working well with health and social care in a very rural area like that. But equally, we've been to the Old Hospital Trust in the Moor and Derry, we've been to West Belfast and also Ballymena and other places. So we have seen some of this working. But hopefully that has helped you understand where we are. It is very much the design phase, so we're interested in feedback, of course, and we can answer any questions. Thank you.
Okay, thank you for that. So, I mean, essentially, we're in the design phase, but we hope to have something operational from March 2026. And we're designing, you're engaging with stakeholders and you're discussing funding packages. And Minister, you talked about workforce being key. Obviously, workforce is very key. I don't think there's anybody in this room, I'd be surprised if anybody in this room disagreed with you in the need to change. But key to change is going to be having a workforce that's compliant and wants to change along with you. And I mean, you talked about GPs, and from what I can hear from Cathy and what we've seen in the presentation, GPs are going to be crucial in terms of the rollout of any new proposals for neighbourhood models. And yet we have a scenario where the department and GPs are currently at loggerheads, a dispute, whatever way you want to frame it, over core funding for this year and core funding moving forward, and we're designing a model that will be, GPs will be crucial in leading whenever we don't have an agreement. So, I mean, essentially what I want to suggest, Minister, I mean, thankfully you have put on record today that there is some light. I think that's welcome by everybody. I think, I mean, we've been in a dispute that we shouldn't have been in, to be quite frank, and we want to see an end of it. In terms of, I mean, I'm not going to ask you about the ongoing details and discussions you're having with GPs about core funding for this year. I mean, other than to say that I hope that brings success, because we do need to see a resolution to that. But in terms of what we're discussing here, shift left, additional workload, I mean, what kind of conversations have been going on with GPs in this phase that can give this committee some satisfaction that they are on board with what you're suggesting? Because the last thing that we, I think, as a health committee or as a society here in the North want is at some design phase and announcement in April, and GPs turn around and say, well, hold on a minute, we haven't been part of this conversation, we're not in agreement with this conversation, where's the funding that allows us to do the things that the department wants us to do? So essentially, I mean, it's kind of, I'll leave the current funding negotiations, but I want to be secure.
Yeah, okay, I get you. So as a final comment on what I said about hoping to get to negotiations, I got a letter back from the chair of the Northern Ireland General Practice Committee yesterday, outlining what I hope will be the 3 phases of the talks, and making clear that they wish to treat the elements of what we're proposing to be confidential until they finish their internal discussions, which is phase 2, and I hope we're all happy to accept the validity and the reasonableness and sensibleness of that. In terms of discussions with GPs, yes, the committee is in dispute with us, but that has not prevented us from talking to individual GPs. And I am now going round some of the federations. So yesterday it was the Southern Federation. So we are having discussions about the neighbourhood model and how they see it, because it is incredibly important that they feel they have ownership. I mean, we're all familiar with the principle of co-design. We're very open. And I take you back to what Professor Benkoa said to me when he was here last October. You need to be really tight on your outcomes, but you need to be really loose in how you achieve them, because you are not a nurse, you are not a doctor, you're not a, you know. So in saying we want to shift left to a neighbourhood model, that's the outcome I'm looking for, but how we achieve it is not down to me or Cathy or Gearóid. We can input into that, we can facilitate discussions about it, but they will do it. And finally, you might have come in, Gearóid, but I was just going to say, you know, the sort of thing that works and has already been done was vasectomy was taken from secondary care and put into primary care. And the money went with it. So things like that can be added in, but I don't want us to be prescriptive. I want the people who are going to deliver the neighbourhood model to say, this is what we can do. Because when I talk to people, they're always saying, we could do so much more. So let's let them do so much more.
And the resource will follow?
Wherever possible. But also remember, the ambition is, if we can do prevention and early intervention, we might take some of the pressure off the acute where all the expensive stuff happens. And if we're doing a fewer of those expensive processes and procedures, then you actually start a money flow. It is swimming against the tide of an increasing and elderly population, but it is possible.
If I can come in on that, Minister, I suppose, as the Minister said, so we are in, you know, we haven't been in formal contractual agreement with the GPC, but we have been engaging with individual GPs. Minister's been engaging with the Federation support units. We had a workshop with GPs specifically, that's including BMA representatives, the Royal College and Federation representatives and individual GPs. So really to try and bring them with us, explain to them what we're trying to achieve and get their feedback and their views on it. What we've presented to the GPs and to other stakeholders is along the lines of what you've seen here today. So we're not starting with a final product and asking them for, well, where do you see yourself in this? We want them to work with us on what is the best fit for Northern Ireland. You know, we want to set the objectives for what we want to achieve, the ways we want to work, and then I guess a mechanism or structures that will allow us to work in that way. We're not going to impose that centrally, and some of the feedback we've got from has been, you know, I guess a concern that there's going to this shift left means that work will come their way, but without the resource attached to it. And I think there's been criticism of that in the past. As Minister's outlined, I mean, the vasectomy is a good example of the lift and shift where a specific service is moved from one place, the funding goes with it. But as Cathy's outlined too, one of the big strands in this is working more efficiently within what we already have. So, you know, through neighbourhoods, if practices can work better either together or work better with community and voluntary partners to provide better outcomes for patients, better access, that's not necessarily going to have a big cost attached to it, and it won't necessarily be more work for anyone in that mix, but it will be them working with more purpose to agreed objectives and agreed outcomes. So we are hopefully will be in a place where we can have more further formal engagement with them on the model. But so far I think there's interest. Some see opportunity, some see threat, and we want to make sure we understand all of that so we can arrive in a place where everybody has got agreement.
Yeah, and we're not in an ideal scenario, and I understand what Cathy said about not everything is going to be agreed by April, but April's only 5 months away, which isn't a long time. And not to repeat myself, you're talking about engaging with individual GPs. After we've heard 90% of the GPs making a decision on Saturday past. So I urge again. I think in terms of the steps of this, the priority needs to be finding a resolution with GPs on core funding to allow this later next aspect on neighbourhood models to have the flow that it needs, because as I say 5 months isn't a particularly long period of time.
Well, the meeting with officials is imminent, and after that it's up to the committee to go back and do their internals. We are ready and the door is open.
Thank you. I'll not push that. Again, same issue, workforce. You mentioned the issue of domiciliary care, social care staff. I think it's important to put on record just disappointment at that decision. I had asked yourself and the Permanent Secretary and others at various committee meetings about the commitment that people expected to get their pay in September. And so I'm obviously very disappointed for the staff themselves, because nobody should be working in our health and social care service and not getting the real living wage. So there's a vital disappointment for that. But also in terms of the shift left policy, the winter preparedness plan, social care staff, domiciliary care packages are absolutely crucial to that. And we have received a letter today from the independent sector that again expresses disappointment and asks various questions, which we will be forwarding on to yourself. But it would be useful maybe at this stage to get your sense of any potential impact on the sector, on winter plan, on any of the strategies that you have that will come about as a result of a disaffected workforce and not being able to retain and recruit staff that are key within our health service.
Well, first of all, the decision is counter-strategic. So nobody in their right mind would make that decision unless they absolutely had to. And there was no choice because the money did not exist. And as to the impact, it is hard to say. You've identified the real and present dangers, which are attracting staff and retaining staff. But we have to look at it in a bit more detail, because it's only just emerging, certainly at my level, that the majority, we think 70% of employers are already paying the real living wage, or maybe even above it. So the impact will be 100% on those who are below the real living wage, but the percentage who are on the real living wage may be a lot lower than was anticipated. So it's not possible at this stage to say to you this will be the impact, but these are the areas that might be impacted.
So, I'm a wee bit confused, because you've taken a decision to say you can't pay the real living wage because you can't afford it, but you're now saying you're not sure the impact was as great as you first thought. So, I'm just...
The impact on the number of people, but
yeah.
It still means the money, the 25 million.
So it is 25 million regardless of what you're saying, that it's not everybody. Okay, fair enough. My last question, again, on workforce issues. So I had asked a written question to yourself in relation to the number of people on waiting lists. So there's nearly 22,000 people currently on waiting lists for occupational therapy. Again, a key component of shifting left. So there's obviously a clear need to address the capacity within the challenges of occupational therapy and within allied health professionals who are delivering currently community-based care. So again, I'm just asking what steps are being taken to build that workforce to help address the strategy that we're talking about today.
Okay, Chair, I don't have the specifics on OTs. I do know we put a very significant investment this financial year into AHPs, but off the top of my head, I'm thinking speech and language therapists did very well. I would have to, if you want, I can certainly get the information to you.
I think that would be useful. As I say, all of this is vitally important to the strategy of shifting left, ensuring that we have the adequate workforce to do the things, and allied health professionals are obviously just as key as doctors, nurses and all other aspects of our health service.
Just so many stats my little brain can't absorb.
So it'd be useful if you come back to us on that. So I'm going to just go around the room now. Diane?
Chair, and thank you, Minister. I am glad to hear that there has been some movement forward in relation to GPs. I don't think that what happened earlier in the year was sustainable, and it is regrettable that those kind of relations broke down, but I am really glad to hear that we are where we are, and I wish you success with that, because without GPs who see over 90% of every one of us, you know, and have most healthcare interactions with people, we can't manage our health and social care system. So I want to place that in the record. I think that is very good and very important. I also want to say that I completely agree with you, and I will give no political cover for any kind of hybrid model that moves away from the core objectives of the National Health Service, which is free at the point of delivery. And I think that is also really important to have on the record, because I think this chatter is chatter and needs political will to deliver it, but I will not be serving that up. So then, just to try to help us understand, so the negotiations are going to be about the contract for 25-26?
I'm going to respect the committee's desire for confidentiality as to the elements of the package.
No, I don't want you to say any money around. I just want to understand
that would be an element of the package.
But I just want to understand the impact on the budget. If the budget is in significant difficulty, will it add to that significant difficulty? That's all I'm asking.
Again, that would be to divulge part of the package which the committee have asked is confidential.
I do not expect you to negotiate in an open forum. That's fine. But I just think that we will need to understand the impact on the budget and whether that would create a further overspend and the impact on that then on the 26-27 budget.
What I could say is if it didn't have an impact on budgets, I don't think it would fly.
No, neither do I. So, yes, but just trying to tease it out as well. In relation to the 25 million that you've quoted for health and social care workers, you would be paying that 25 million irrespective of how many people needed it to achieve the real living wage, I take it. Yeah?
No, I think that was the calculation that the officials made about supplying it. But what I wasn't aware of was that a significant number of people are already they're on the real living wage, but that's being paid by their employers.
Mm-hmm. Yeah.
So what we were proposing to do was to put money into the system which would allow employers to pay their people the real living wage.
So the department was taking responsibility for paying the real living wage and not the employers?
We were giving them the funds to achieve that.
I'm finding that difficult because you're saying that 75% are already on it. I mean, I think it's the right thing to do. I do think it's the right thing to do. I think that to expect people to work difficult work, without at least the real living wage is very important. But I'm just trying to understand, if you say that 75% are already on
70.
it, or 70, whatever that is, but you're still intending to pay them the 25 million, maybe we could have some clarity in that. Because one of the things that does come up in the office on a fairly regular basis is the issue of top-up fees for nursing homes, and the amount of money that people have to pay over and above as well. So just so that we can have a sense of that budget and how that's worked out, I think is quite important as well. I'm a bit like the chair. I am concerned about the timescales here. I think that if we're only designing something, and I've spoken to a number of GPs and so on, who agree with the approach, think it's the right thing to do, but the time scale is very short. And I would worry about that. And how can we have confidence that we can deliver within that time scale when 14 months after launching the hospital network document, we as a committee, unless it has been delivered and I haven't seen it, haven't received the consultation responses on that? I've just been reading the ministerial or the reset plan and the delivery commitments, and it says by September 25 we will know the outcome of that. Sorry, I just can't find it now at the minute, but we will know the outcome of the hospital network programme or the paper, but we don't.
Look, without a doubt, the timescales are really challenging for this, and I suppose that's why we're stressing that we want to get to the starting point, a starting point by April, and I think we will be in a position to articulate the model and the funding model as asked. But we certainly will not, as I said in our remarks earlier, we won't have a fully blown neighbourhood model for a long time. That'll take a long time to develop. But it is the beginning of it, and I think that's what we're working with. Our stakeholders, funny enough, the views are mixed.
Yep.
Some stakeholders are saying, as long as you're given to take it is as long as you'll take. You could be at this for years and years and years, and there's no doubt about that. We could be at this for years. Please just can we get on with it and get started? Others would like a lot more detail at this stage, and even within the same stakeholder groups, they're saying no, don't give us too much detail. We want to inform how this develops. So look, we're focused on it. Is all I can say. We're focused on delivering it within delivering a model, describing a model and the funding to support that by that time to allow something to commence. But it will be very much to begin from
how much work then has been done? I mean, if I've got this right, you identify 4 different types of funding that would be needed for this. Mobilising what we're already doing, I don't quite know what that means, but I'm sure you do. And identifying funding from HSC budget money to invest to shift, and how much agreement is there? Is there agreement in relation from the trusts to move that money across? Because I always think that's the big issue, the difficult issue. And then, the provider alliances, so say GP federations. And I talk to the Southern GP Federation on a fairly regular basis. And they do have some brilliant ideas about how they can improve community health.
Respiratory?
Exactly. So I think that's quite exciting to hear.
Fabulous.
Because for some reason or other, ABC Council area is some of the worst respiratory health in the whole of Northern Ireland, and they have really good ideas about what could be done to do that. So I think that's quite exciting. Provider alliances getting funding from other sources. It's pretty hard to get funding from other sources. It's difficult. I just think it's vague to me. It's vague.
Well, part of it's necessarily vague at the moment because in terms of budgets, we don't know what our budget's going to be, and we are anticipating a 3-year, multi-year budget. So every penny we try and carve out of that for the shift is going to be difficult because it potentially has implications for current service delivery. You get that. But the other thing I would say is that my colleagues are making the point that some see this within the sector, within the service, as opportunity, and some see it as threat. And I think they're right to, because there are a lot of models. And Cathy and I were in England a couple of months ago looking at some of the models. And one of them, frankly, I really disliked. And the reason was, it was a really commercially driven operation. So they don't have federations, but they do have PCNs, primary care networks. And in this network in London that corralled them together, and it was all, triage was online, and to achieve scale, they might have been saying, well, look, Mrs. Dodds, your nearest GP, the one you normally go to, is Dr. Cassidy, but I want you to go to Dr. Harrison because she specialises in what you want, and we are so commercially driven. We're just sending people 3 pillars: emergency care, planned care, people with long-term conditions, and preventative. And they try to get each practice to specialise in one of those pillars. That model I don't like, nor do I think you could apply it in Northern Ireland, because our practices are all independent practitioners. Mm-hmm. So we need to overcome the fear and the concern of the GPs who are maybe thinking, I wonder if they're thinking about that model, to reassure them, no, we're not. We're talking about a model that works for you, with a role for the federations. I mean, in terms of scale, all I would say is this. They reckon in England, once you've 40,000 patients, you can predict really accurately your demand. Federations are nearly 3 times that size at 115,000. So we should be able to sweat that to predict demand much better than we are. Much better than we're doing it at present.
I do think providing care closer to people in their community is the right way forward. How, and I wish you well with it, I genuinely wish you well with it. I think the timescales are almost impossibly challenging, but we'll leave that up to you.
There's very little left in the mandate, so we can't really do it.
And I accept that, and I do wish you well with that. I do think it's important. You cannot do it without GPs, you cannot do it without the hubs that we have the allied health professionals in, etc., etc. So there's a huge job of work to do in relation to all of that. And I would say that I'm a huge fan of women's centres, and I think that in utilising community facilities, I think there's an open door. Brilliant one in Craigavon, Shankill, I know you've been up.
I've been up a few times.
Yes.
And they were delivering the Live Better initiative
Yes.
to try and tackle health inequalities. And the point, sorry, I forgot to make was, we were able to bundle existing services and without any real additional budget, deliver that Real Better initiative in places like the Shankill Women's Centre. So that neighbourhood model can absorb that sort of thing of saying, we're already doing this, but let's repackage it and deliver it as close to people's front doors as you possibly can get.
And just to respond on the timeline, it is very challenging, but it's not the timeline to a finished product. It's a timeline to really a concentrated starting point, and it will grow as we develop. We won't be looking to try and emulate every good service we see, but it's important to make a start, because we've been talking about shift left for a long time in health. We've started it in different ways, but this is a real concerted effort to try and move forward as one across the entire system. And yeah, I mean, by springtime, by April, we'll have basically the playbook for how this will work. We won't have the fully built product.
So can someone come back to us really in relation to social care workers? We're really keen to see them being rewarded appropriately, but I'd really like to work out how that's being done and an idea of when we would see the outcomes from the hospital network consultation. Thank you, Chair.
Thank you, Colin.
Thank you, Chair. Thank you, Minister, for your presentation. Call me cynical, but if I even think of just about back to the time whenever I was studying health and social care and looked at how the trusts were realigned and how the department's boards were realigned, and then we've changed the boards again and we've moved into an SPPG that is different from where it was. We flirted with integrated care partnerships, and then we're now talking about a shift left. And yet the front page of the Irish News talks about Ernie Irvine, who was treated on the floor of a hospital for 48 hours with stage 4 cancer. And sometimes it feels like, and it's not just yourself, there's many ministers before you, that what we do is we talk about a system and then we get really excited about a new system and we go through phases and we go through plans. But just like a set of gears, we just don't get to connect it then sees the change on the ground, because people are interested in seeing a doctor when they need to see one, having an ambulance when they need one, and when they go into an ED, that there are treatment for them there and moved up onto a ward. So what comfort can you give to us that this plan, when it's implemented, will mean that people like Aimee are not going to be treated on the floor for 48 hours in what's supposed to be our health service, and that if people need to see a doctor, they'll see one? Where will the tangible outcomes be that we can prove to people that this is going to work?
So I will start with another reference to Bengoa. You'll remember his report was called Systems, Not Structures. And you began by talking about a lot of structural changes. And I have said I will not engage in structural change during my time as Health Minister. I would love to, by the way. I think rather than having 5 geographic trusts, we should have a paediatric trust, a cancer trust, a mental health trust, etc., because that's how you get, or your best bet at getting regionalised, standardised services. But if I called that now, with a year and a half to go in the mandate, the whole system would grind to a halt. So shift left, Colin, is actually about a system change, about saying let's think about prevention, and when people start getting sick, let's get in as early as we can. Because the man who's lying on the floor, and I apologise, that should not happen. And the best chance to preventing it happening is to take a bit of the pressure off those acute hospitals. And the best way to do that is to get in early, on the ground. And we know when you deliver health and social care, either in somebody's home or as close to the front door as possible, that's when the uptake is so good. For example, the Shankill Women's Centre, we're doing some of these drop-in centres where you could go and get various tests done. Every time I went, the place was buzzing. And I think the same up in Derry. And also, just to diverge, those 2 demonstration areas were asked, what do you want? And they picked different things because they understand their people. So I think the shift left will work because it's system rather than structural. And how will we know? When there's a bit less pressure on the EDs, when ambulances aren't sitting for so long in the car parks, and we've got a better flow out into community care. And the big challenge is capacity in community care, both in terms of care home beds and home or domiciliary packages, as we used to call them, which gets me back to the real living wage. It's counter-strategic.
Could I add to that about demand? And I think this is one of the, and you ask it's a really important question, and it is something that we've been spending time thinking about. What do we need to see first? What do we need to start to see from the beginning next year? Bearing in mind, yes, we're going to have to work through large programmes like shift in activity out of hospital and all that will take time. But by bringing provider alliances together and using all of the resources we're already investing in, I mean, this is what is so apparent when you're out, when you're out in communities and you're seeing all the services that are already there, that are already being funded. And I'm not just talking about health and social care, I'm talking about voluntary as well. And what we are hearing all the time from stakeholders is if we were working more together, we're calling it working with purpose, kind of like we did in COVID, where we worked together with a smaller number of priority areas. But here, then, if we all work together and we just focused on let's try and keep our people out of hospital, understand our highest risk people who live in this neighbourhood and understand their needs and get into proactive care so we can keep them out of hospital. So reducing unplanned admission to hospital, therefore reducing unnecessary ED attendance as well, and then the conveyances to hospital and the pressures on our ambulance service. This is what we're seeing in neighbourhood models, and this is where we're saying start to work together like this. Obviously, as a pharmacist and as chief pharmacist, I'm very familiar with the role of the community pharmacy, and we've been investing in more services there, and we want to invest more. We're going to have a lot more prescribers in that sector very soon. But we have been investing in more services. But when you're in the system still isn't fully utilising those services effectively. We're hearing the same from voluntary and community sector. We're saying we're funded to provide services, but actually there's duplication in the system. Maybe there's a trust-led service that looks a bit like this. So that, I think we really do have an opportunity to get started with in those provider alliances, and that's where the evidence is showing that when people do start to work in this way, that's the key outputs that they're starting to see to begin with.
And I think there's 9 members of this committee, and I'm sure I'm not speaking out of turn to say that we're all behind you, because we want to see the change to the system, because the system is so broken and it's not working for people, in reference back to Ernie. But I fear, and I know that you have to do it for presentation purposes and in a document, and it just feels like a lot of terms that I've heard before, you know, let's circle the environment, let's think of new ways, let's scan the horizon and think of new... Is there a way that we can start to get some real concrete information in the reports that we can actually look at? Because whenever you talk about community pharmacy, I go, yes, if you put X amount of money in the front door of that, that means that people that would go to a hospital won't. They'll go to the community pharmacy instead. That keeps people out of ED, which means there's more space there, which means there's less. You can start to see it when it's really tangible. So is there a way that maybe we could get some information that gives us even an example under each of those? Because you don't want people to say it's just buzzwords, you know.
I think that's a fair point.
Yeah, no, it's a fair point, but all I would suggest to you is, if we did there's a plan, it's really solid concrete, the GP committee would say, oh, thanks for asking.
But I think we can definitely provide, that's the next...
Or even a headline of what the change could be, so that we can say it's there.
These are things that are possible, these are things that aren't possible.
This is something that we are building as we're talking. So if we'd been presenting to you a month ago, there would have been less detail in the presentation. It is growing, and we are mindful of the timelines around this. But I think that's a really fair comment around. I mean, the next iteration of our design presentation will need to have more concrete terms around what the kind of outcomes we want to see and the kinds of shifts we want to see.
Okay, thank you, Chair. Thank you,
Colin. Nuala?
Thank you for your presentation. Today I just have a few questions. I'll start and pick up on that last point, and it is really good to see that we agree that we do want to transform the health service, but would you agree, Minister, that actually it shouldn't be political, transforming the health service, and that we should have buy-in, but ultimately this shift left isn't new, and it has, like you've said, been an idea long ago. Bengoa talked about it many years ago, but it does taking the politics out of health and actually moving forward. Would you agree?
Yeah.
And
I think it was around before Bengoa even.
Yeah, it was indeed. But I also want to talk a little bit and go back to this hybrid issue. I also agree that NHS and the creation of the NHS after the Second World War was a massive change for society, and really tackling health inequalities, tackling poverty, and we shouldn't have any hybrid models of GPs, like that. It shouldn't be an option. But would you also accept that we already have it when it comes to dentistry, which is also a part of primary care?
Yes, it would be my understanding that when the health service began, that without a hybrid model for dentistry, the whole NHS was going to collapse.
But our constituents can't get access to dentists. They can't get access to the GPs some of the time, but they also actually physically cannot get registered with dentists. So how will your shift left agenda aim to tackle that issue in particular?
Well, we have put several million into a dental access scheme, but they are independent traders and we cannot force them.
What else can we do to get more people? Because the dentists are telling us that they can't offer services when they're not paid for the cost of actually offering those services.
So what we have done, because there isn't an agreement about what it costs to run a dental chair, is we have commissioned a cost of service survey, and that will lead to some results which will lead to discussions with the dental committee, and hopefully we will agree in the first instance that the cost of service report is accurate, and that will lead to some sort of discussion stroke negotiation.
And where we are on that? Where are we? How long we?
Well, we've commenced. We appointed the lead person from Queen's to lead the review. They've started work on that, I haven't had an update, so we're working towards having that report finalised for the springtime. And then, as Minister said, then that will then form the basis for, I guess, policy formulation and negotiation with the BDA.
And with regards to the dental access scheme, there are many of our constituents that can't actually access the access scheme itself because the way and the criteria that it's made. So I understand that it's limited with the amount of dentists that sign up to it, but is there any way the criteria and the use of which can be changed?
Well, I think we review all our schemes on an ongoing basis, and I've had discussions with the Chief Dental Officer recently around reviewing that scheme. Not specifically for that reason, but I think so we can certainly look at that. It is that, you know, practices sign up to it and then deliver to what they signed up to. If a practice is unwilling to sign up, we can't make them do that. But you know, I think we want to make sure that it seems to have been successful in terms of the rate of uptake, but we want to make sure we understand exactly how it's working.
So the cost of service is being conducted by a Queen's Professor who is due to report by the end of the 25-26 financial year, but I would put in my usual proviso, we're not world leaders in matching our deadlines.
No, we're not. We should be, but we're not. We can all agree on that point. But the 1.6 that you announced for the dentistry, can you just elaborate a little bit more and remind us what that additional 1.6 million, I think, was it for dentists? Have I got that figure correct?
It was 7 million for enhanced child examination, 30% for additional fees for service, fillings, extractions, root canal. And the 1.6 was to support dental practitioners who continue to provide health service dental care to patients. And then 2.5 was made available for general dentist practitioners to offset the increased costs of national insurance contributions.
I don't really understand that 1.2 or 1.6 million. We can go back to it in a written question. We have submitted it, so I'm fine for it to be
okay.
I
think that'd probably be best, but I'm thinking this would be if a dental surgery can prove we have done X number of health service.
In old terms, it's akin to what the old commitment payments were. Now it's not exactly the same as that old scheme, but we can provide the detail on the intention behind it and the uptake.
So the more you do, the bigger slice of the cake you get.
It's incentivised for increased activity in dental.
And it's incentivised for increased activity in NHS dental work.
Yes.
But what if your costs don't? If your costs don't actually cover you being able to carry out NHS dentist work, is it just an incentive? Is it an incentive to pay out of pocket first to get it reimbursed? Dentists are telling us that they're carrying out work, but the cost of recovery from the NHS is not actually covering the cost of carrying out the work. So if they're going to get incentivised to do more NHS work, but it actually is costing them more to do more NHS work, where's the additional money?
It's the cost of service.
And hence the uplift to the fees of 30% across the kind of the biggest category of activity. So we've increased the key rates for what's been done, and then we've added in an extra incentive for people to do a higher volume of that. Okay. I guess these things are all subject to review. So
well, we have a written question, so I'm happy to carry it on.
Anybody have Kilray in their constituency? So the dental service in Kilray is fantastic, doing magnificent work in the NHS. Well worth a visit, Alan.
So I want to go back on the real living wage. We just had a look in January of this year, in 2025. Minister, you were up at the committee and had said that there was an estimated cost of 50 million towards real living wage for home care workers then, but now it's 25 million. So was it 50 or
both?
How?
25 for September to the end of the financial year, 50 for the whole year.
From January. So it was never going to be.
I was hoping to do it from September of this year until March 26 for 25 million, and then in the next financial year do it for the whole year at 50.
And 25 million regardless of the number of people who need to get.
That was the number the officials have crunched out. What I wasn't aware of was that didn't represent everybody who's delivering social care.
So it was always 25 million because not you, but the officials knew that not everybody needed to get.
That's my understanding, yeah.
So how many people get? How many are we talking in its totality?
I don't know off the top of my head. Anybody know the number of people delivering social care?
You can understand our confusion whenever we don't know the statistics that are actually, and the finance that is actually needed to deliver real living wage. And if a decision was made not to actually pay the real living wage to those who need it, without the knowledge that everyone actually needed real living wage, how can we have confidence in the actual decision of itself, notwithstanding the fact that I completely respect the difficulties around all budgets? But how can we have confidence in the decision if we can't have confidence in not knowing all of the issues behind the decision?
No, well, the officials came to me and said if you want to do it, it will cost you 25 million this year because it's a half year, therefore 50 million thereafter. What I've been told subsequently to that is that doesn't cover everybody because a lot of people are already on.
And did the officials know at that time that it didn't cover everybody?
They knew who it had to cover, as far as I know, but let me bring you a paper back.
Need clarity.
I think we do, because it does raise questions as to why the decision was made without all of the information in the first place. And I recognise that your budgets are difficult, and 25 million might not seem a lot in the grand scheme of the whole executive.
It is a lot.
But it is a lot. But there was also a report by the Auditor General about restricted procedures costing 22 million a year. And those restricted procedures were carried out without assurance that they were complying with government policy. I am not saying people don't deserve to have those procedures, of course, but there absolutely must be a priority. So if on one hand we have the auditor saying that there's 22 million on restricted procedures and then 25 million for home care, how many other things are going on across our trusts and our health service where actually that 25 million could have been found? And in that same report regarding the restricted procedures costing £22 million, it was said that that was for the 23-24 year. But in a response from the department, you had said, in response to me from the department, you had said that you were using the practice of that issue of restricted procedures under that guidance to evaluate whether people should be accessing a waiting list. Yet the auditor had said a year before that there was recommendations that need to be implemented. So it sounds like there has been measures that could have been taken to save money by prioritising. And I go back to the 25 million isn't a lot, but that is one snapshot of one issue, and it was 22 million. So can you understand why there are concerns, why home care staff aren't getting the living wage whenever there could be priorities? And again, I respect that budgets are difficult.
There are a lot of judgment calls in health and social care delivery. And in terms of saying, are there other examples where money could have been saved? All I can say is this year we started with a funding gap of 600 million, let's take out pay, 400 million excluding pay. It's now at 91 million. That is an unprecedented effort, particularly by the Trust, but not exclusively, but particularly by the Trust. So is there still a bit of slack? There may well be, but my goodness, people are working supremely well at trying to find where the inefficiencies are and cut them out. Saving over 300 million in one financial year. I think that's pretty impressive.
It is impressive, but the issue still stands that it's prioritisation. And
it's a judgment call.
And as Minister, you're the right person, and not just you, to be fair, your whole department, the person to provide with the information as to where the priorities should be and the money should spend. It's difficult, but it has to be done by the department. But I don't have any further questions.
Thank you. Danny?
Thank you, Chair. Like other members, I'm confused about the 70-30 split, that 70% were already getting paid it, but 30% weren't. So I appreciate you're going to bring us a paper, and I look forward to understanding how that works out. We all want to see investment in prevention. We all want to see early interventions because we know this will keep people healthier in our communities and it will keep them out of hospital, and it will reduce pressure on A&Es and reduce pressure on the wards. I hear very regularly from healthcare professionals who are very concerned about the levels. within our hospitals at the minute. We've had ambulance waits all summer. We've had pressures in A&E all summer. We've had corridor beds and wards all summer. Staff are very, very concerned about going into this winter under those conditions. A lot of them didn't have a lot of confidence in the winter preparedness plan without being able to see, what was going to be the light at the end of the tunnel this winter. You came here in January the 7th, I think, and promised us that this winter would be better than last winter. So, we're very concerned about plans that are coming, not being able to deliver. This plan that you're giving us today, can you tell us how are we going to measure, what specific metrics are going to be used to progress, or being used to measure the progress in shift left? How are you going to know that it's working and to how?
Well, we haven't populated shift left, as we said, and I take the point from Mr. McGrath that we need to put some more granular detail on it. But until we say it is this, the next vasectomy is X, Y, or Z, it's very difficult to say there's a matrix by which we're going to judge it.
But the type of metrics we will be measuring are, are what I have already mentioned. They are going to be focusing on those key metrics that indicate demand and on the system, such as unplanned admissions to hospital days, such as ED attendance, the rate of ED attendance, such as our conveyance rates from NIAS. We're working with NIAS as well in this work. And also and that's sort of in terms of managing current demand, but also then in terms of shift left, I suppose what we've been interested in, and we're looking at this in different models. So we're looking at what difference has it made? That's the right question. We have to see what difference is this actually going to make, and how quickly could we start to see that. In terms then of shift left, in terms of activity, that the activity shift, that needs to almost be now specialism by specialism. We need to go, where would you start? Where would have the biggest impact, and how would we measure it? And some of the models that we have looked at, for example, have been able to demonstrate things like GP referrals into specific specialisms, because the GPs and the neighbourhood approach is holding more care for longer. Within the neighbourhood without having to be involved in trust. So they're the key metrics that we're going to be looking at. I think one of the things that we're interested in is, can we keep this quite high level like that? There's no shortage of metrics in the system. Everyone is measuring lots of stuff. There's lots of data as well. But can we look at, what do we want to see first? And they're the areas that we want to look at, and because they are also areas that people can see the impact they can have on that by coming together. So there's,
and that's the things that people are describing to me from inside the health service. So that is your unplanned admissions, that is your pressure on A&Es, that is how long people are staying in A&Es, corridor bed waits, and how long medically fit patients are waiting in discharge. I'd asked you a question, I don't know if you'll remember now, it was in about October, about how many medically fit patients were waiting on wards in Northern Ireland, and it was 400, nearly 400 at the time. Now, that wasn't even into the winter, so those pressures were already there. Yeah. So, the left is where the shift needs to go. It's those community workers. I have heard from carers who were really, really disturbed that they weren't going to be getting the real living wage that they were promised. What are you going to do to reassure them that we are investing in that community sector? We are going to be able to make the flow through the hospitals easier by building capacity in the communities. Yeah.
So there were three things that I wanted to do. One was more pressing, not more important, but I would say more pressing the other, and that was pay for nurses and doctors, because you are aware the RCN and some of the unions were very close to balloting for industrial action, and the RCN had written to me to make clear industrial action was strike action, and it was strike action without derogations. And I was sitting beside the chief nursing officer when we had that meeting, and I was scared and she looked scared, because no derogations was a very serious escalation on last time. So that was the first thing, and I think we've got there on pay.
No derogations at all?
At all, they said.
Right.
I know I find it hard to imagine, but when I imagined it, it scared me. And we've got, they wrote to put it on paper. Then the second thing was the low paid, because I'm very unhappy I'm just not content that there are people earning even less than the real living wage. I would like everybody to be earning more than the real living wage. So I want to address that, and we are in the foothills of a plan which will address that no later than start of next financial year, is my ambition. And the third thing, and you will know this, it's not about the pay per se, it's about banding, it's about where you are. So you can qualify as a nurse and very quickly become a band 5. You can have a career of 20, 25 years and leave as a band 5. And the RCN have made clear to me that is a real big issue. Plus the band 1s and band 2s. So pay and career progression and development. So those were the three things. And in terms of the winter preparedness, yeah, I mean, I went to, I think, 7 of the type 1 EDs last January. And it was awful. And you know, to go and say, I'm ultimately responsible for this. So that's why I said, look, let's take a blank page and let's get everybody in the room. Back to the Bengoa thing. I'm tight on the outcome. I want better next winter. But how do we achieve it? I don't know how to achieve it. But you're the nurses, you're the ED specialists, the emergency care. We had everybody in the room. So I'm not going to criticise the plan. Because if that is the best that the professionals are coming up with, I accept that's the best the professionals are coming up with. But I also accept other people are looking at it and going, that's not much better than last year. I'm not particularly hopeful.
Sorry, Minister, it's your plan.
I'm owning it,
yeah.
But I didn't write it. Right. I said, get everybody who knows how to do this into the room with a blank page.
You didn't write the winter preparedness plan?
No, I didn't write it. I signed off on it, and I will own it.
Yeah.
And if this new flu that's coming early knocks us for 6, buck stops with me.
Okay, Minister, you mentioned workforce there. Something that has come to my attention recently is the rise in vacancies across the health service. You may be aware there's currently 6,310 vacancies across the health service, a vacancy rate of 7.3%, something that I think has gone up by about 15% in the last year. Nursing and midwifery account for most of them with 2,098 vacancies. That's 1 in 3 of all vacancies. Well, what's driving these rates? Is it lack of recruitment? Is it lack of problems with retention? What are you doing about it?
Well, I discuss with the Workforce Directorate all the time about various issues, including vacancies and retention. But I'm afraid I don't have any information with you because it's not really absolutely... Is it actually core to talking about shifting left? Having the right workforce is, yes, of course it is. Yeah. But that kind of granular detail I don't have with me.
Okay. Well, no problem. Well, okay, I'll submit to another question if you don't mind. Community pharmacy has been mentioned in the reset plan and the winter preparedness plan as being a key pillar of the shift left. Can you tell us how much funding is going to go into community pharmacy and what the roles and responsibilities may be then?
The funding is already in the system. There's for community pharmacy this year, and that funding was agreed at the beginning of the year. And decisions were made earlier in the year as well to extend access to the Pharmacy First service, for example. And so there was a small amount of money put into that, I think, and earlier in the year, but that was all done in advance of winter. So that's why the winter plan actually represents community pharmacy very well in relation to their contribution to the health system this winter. So those decisions were already made recently. Of course, community pharmacy will benefit now from the decision on the pay uplift because in Northern Ireland they are aligned with the DDRB. So they will benefit from that, and they will benefit from the 4%. So that, I think, understand. So that will be the additionality that'll go in to the system now in the next few months. But other than that, the money has already been in the system for community pharmacy from the beginning of the year, with maybe some additional changes like extending some of the Pharmacy First services for shingle and sore throats. But that's all articulated in the winter plan.
Can you tell us anything about investment next year when this plan, the new plan, will come into it, the neighbourhood plan. Can you tell us how much you're investing in community pharmacy, who will be a key part of it?
Well, the commissioning, we were actually, just in the last month or two, we agreed the commissioning plan for the next 3 years with CPNI for community pharmacy. And in that does set out some ambitions around service development. And we will be in the department, like everyone else, looking to see what money, additional funding we can secure, in particular if we can, if that is in the context of a 3-year budget. But right now we don't have figures that I could share with you on that, because the budget, as the Minister said, is not yet known for that. But what we do have is a clear direction, and we have a clear agreed direction with those stakeholders of what we would like to invest in first. And I think they're very well set up in the context of neighbourhood, very well set up. And also from next summer we're going to have our student pharmacists coming out as prescribers, so we're already designing the services that will allow them to be able to prescribe it. For example, within Pharmacy First, they'll be able to use those prescribing skills. So I think they will, we benefit from having a clear strategy and also the commissioning plan for that sector.
So the budget this year, 158.7 million, which was 11.7 up on previous year.
Thank you, Minister.
Very quickly, Dan, I need to move on.
Yeah, no problem. No, thank you for your answers.
Okay, Linda.
Thank you, Minister, for your answers so far. So I suppose one of the things that I want to raise is something that I actually raised in the motion during the debate, in the chamber the other day around the cancer waiting times, and that's the Encompass system and the investment into it. And if we're talking about shift left, that level of investment must deliver more than just we have new IT infrastructure, isn't it great? And I can see my results, which I think is a good thing. I'm certainly not been negative about the actual system itself, but we have not integrated primary care. So GPs, pharmacists, none of those people that we're talking about in this shift left are included in Encompass. So that means we don't have a single accurate view of every patient's journey. And without that, how do we create really good pathways? Because that's our biggest problem. And shift left will only work if we've got really good pathways, because it's about doing everything you can on the left, but absolutely making sure that the left has somewhere to send people that need to go to the right, because that's not happening right now. I mean, I'm sure everybody here can give examples, but I could give you 2 examples in the last week where people have had repeated visits to GPs and EDs and were sent away and now are costing your health service a fortune because they've had surgeries to stabilise them, PET scans, MRIs, CTs, repeated visits to consultants, and now we don't know where their journey will go, so, or where they'll end up. So that's really concerning. So I don't know how we manage those to get those pathways right and ensure that the highest risk cases are going where they need to go and the backlogs are managed safely. So, and looking at that diagnostic treatment stages and where the bottlenecks are. Encompass should be allowing us to do this. If it's not, why is it not? When will it be able to? So for me, Encompass is absolutely vital in this whole shift left. And I am 100% behind the plan to shift left. And I also would like to see a specific, I suppose some specific mention whenever we do see the plan around how we're going to better look after women's health in this shift left, because at this minute in time they're being failed day and daily.
I just recall when I got the first day brief, being surprised that Encompass didn't cover primary care, but there was a good answer to that. It was partly because they're all independent operators.
It was, Minister. I actually met with the department before the assembly was re-established. I had met with the department around this, and I raised it at that time in those meetings. And yes, they said that, but I did say to them, if you're serious about this, if you don't give any additional funding to GPs for anything else, why would you not look at looking at some way of funding GPs to be part of this system? It was the department that came up with the idea. It was the department that decided this is something to do. This is a good idea. It's going to work. It's going to improve our health service. So why did the department not work with GPs to say, how do we include you in this? How do we make this work for everybody?
In Northern Ireland now, we have the Encompass programme brought in one single system for all of our trusts, and also in general practice now, all our general practices are moving to one system, Aimee. And look, it isn't obviously strictly my area, but I have an interest in it because of the neighbourhood work, and we are looking at this, and the whole digital infrastructure, as you are right, is absolutely going to be critical. And my understanding is Aimee and Epic can work together, and there is a programme of development that will allow that. Also, we have ambition around electronic transfer of prescriptions. We also have ambition around digitising our community pharmacy services that are all paper-based at the moment, remember. So we have real challenges there on scale, and those changes over the next few years, and I suppose that's to stress again, the neighbourhood model is going to be long-term change, and as these changes come in, we will need all of those digital systems working together, and a programme to support that. But that is on our radar. Moving into the next stage, building the programme to support neighbourhood will include working very closely with our Chief Digital and Information Officer and his team to have a dedicated digital programme to support this, and also the data that hasn't been mentioned. We have so much data in the system, but we don't necessarily have the data to hand that can clearly articulate the impact that this will have, but it is out there. So that'll be another ask of that team, and also and a focus on improvement. But it's a critical component of progress. You're right.
So my last point on this, and apologies, Gearóid, if you don't mind to make this point first, because you may be going to answer some of this for me if I get it across right. So I understand that people aren't in the room necessarily that are absolutely understand how Encompass works, but if we can even get a written paper, because I do need to understand. I know that the GPs are moving to one system, but how will it then work together in terms of the data collection, looking at how we have the better pathways? I need to know that is absolutely 100. I want to see it. This is what will happen here. This is what will happen here. This is how we get the outcomes of it, and this is how it'll create better pathways, because we'll have this information. So I just want to understand that, and if there's a problem with it, if there's going to be some blockage somewhere along the line, tell us that. If we know it, I won't come back to you saying, why did you not tell me that? So just tell us if there is going to be an issue with getting that kind of information, because this system needs to be used to collate information that's going to make life better.
Well, we can come back with some more detailed information on that. I think one of the things I would say is that in terms of ownership of data, so each individual GP is the owner of their data, and that does present challenges in sharing it in other systems. So I'm not saying that's necessarily a hard stop on a single system, but it is something that would need to be navigated. But we can provide more information on that. I was going to add to what Cathy was saying. We're at the early stages of this. The data and good data around where patients are, what their conditions are, and how they've been accessing services is really, really important. We started some work on, and it's been part of our kind of road shows, is kind of doing early demos of this around mapping. So we've got pretty good maps now of not on a federation level, but drilling down to individual practices, what their list size is, what the kind of key morbidity indexes are, and we also know that in the PHA they've got some really, really good data on patient need and morbidity. So bringing those things together, we are creating a really powerful tool that will enable those neighbourhood teams to really understand at a touch of a button or a few clicks of a mouse who is in their neighbourhood, what their needs are, where are they in relation to key services like their nearest GP service, the nearest community pharmacy, their nearest ED. I mean, that all helps to bring together into one place some of the disparate strands around what services are out there for people. It's incomplete because we don't have really good, reliable information on the community and voluntary sector, for example. So that it'll be something that we look to build into it. But as a decision-making tool and as a planning tool, it'd be really, really powerful. But we can come back on the Encompass
and the pathways, and I know that is something you are looking at as a department, so I appreciate that, but I definitely would want more information on that.
Thank you. Apologies, with 3 speakers left, I'm going to have to ask the 3 to be very succinct and ask questions and very succinct answers. It's my fault as chair that I'm allowing things to overrun, so apologies to our last 2 speakers.
Yeah.
I know Alan's not going to quiz you too long.
Whatever do you mean?
Minister, I and my party certainly welcome your outright rejection of the introduction of the new hybrid or charging model. I've been listening carefully to GPs on the media over the last few days, and some of them have raised different views around the issue. Is it your view that rather being an agreed view of all GPs, that many in fact are wholly opposed to the idea of a medical card type scheme?
I would say you've got the whole spectrum of opinion from individual GPs who want it. Just, it is their desire to have it for themselves, right through to, over my dead body, would a GP support anything other than free at the point of need, and everything in between. What I couldn't do is quantify or give you numbers from A to Z, but I'm absolutely convinced that you do go from A to Z in terms of opinion.
Yeah, so certainly
and
not.
I do welcome the fact the Royal College came out and said that they wouldn't support a hybrid system.
Yeah. Cathy, just the focus of debate really has centred on GPs sort of recently over the shift left, but I also see the community pharmacists as playing a really important role going forward. So what sort of appetite are you getting from pharmacists on the ground about working with the shift left? And would I be correct in saying that under a new community orientated model, the financial sustainability of pharmacies would actually be much enhanced?
Well, as part of our sort of workshops, we have been meeting with lots of stakeholders groups, as I said, and actually we met this week with community pharmacy, and we had an excellent turnout after work for very busy people, and we really appreciated them coming out. We had I have to say, all of the discussions with stakeholders are fairly robust. We would expect that. In the room in community pharmacy, we had some leaders from the profession who've already been through LCGs, and they're involved in AIPBs at the moment and different things. So they've already seen different models that have attempted to support change. But I think overwhelmingly they support the need for change, and also I think as a sector they do have a clear vision of what the contribution could be. Because of the work that's gone in recent years, to be honest, working with the sector. They do have a clear vision, supported by investment in workforce, supported by clear ideas around what services we would like to offer the public more through that sector. So I won't answer the question of whether they would think it would be more sustainable. Maybe I think I'm back next week talking to you about something like that. But that they may have their own views, as Minister said. I would say it would be a whole spectrum, but certainly it will raise the public awareness even more around that you don't need to just go to one provider for your care, that there will be elements of your care that will be very appropriately and safely provided for in community pharmacy, for example. And that is part of the neighbourhood. That's at the heart of the neighbourhood model, is recognising that. So I do think there's an opportunity for the sector there, very much. Thank you.
Thank you, Chairman. Was that short enough?
You get a gold star. Orlia.
Thank you, Chair. Pressure's on to beat Alan. No, thanks very much for the presentation and all of your answers so far. I'll be very quick. So my first question, Cathy, you had mentioned then the associated funding model, that you hope to have that sort of drawn up and designed by March of next year. Will that funding model target areas of highest deprivation? So is there going to be any sort of prioritisation or special focus on objective need and our areas that are most deprived?
Look, it's an excellent question, and I think it all depends on how the model develops. One of the interesting feelings and views that is being shared is there is a desire for all parts of Northern Ireland to be given an opportunity to be involved in a change like this in terms of neighbourhood, and we have. That's perhaps not how we've operated before. We would have gone into pathfinders or pilots and started in some areas, and there's lots of different. If we did that approach, there's lots of different ways we would, and of course naturally we would look to our most deprived communities. What I would say is that we've been we've been very impressed by the work that was done by the Public Health Agency on the Live Better programme in terms of really understanding the level of need in two of our most deprived areas in Northern Ireland, in West Belfast and the Moor and Derry. And we're looking very much at building on that area. So I think at the heart of the neighbourhood, yes, will always be tackling health inequalities. But right now I can't say, we don't have the detail of how that would manifest into funding, etc. But it is at the heart of this, and I would say we have some of our strongest community and voluntary sector representatives in some of our most deprived areas as well, and just using those assets will be critical to this as well.
Yep.
Thank you.
No, thank you so much, Cathy. And then just finally, Minister, because I referenced it just in the last session there as well, I know that you'll be aware of the NISRA announcement today on the suicide stats for 2024. I know that obviously speaking publicly about this issue, we'll have to be extremely sensitive and sensible, and first and foremost let people know if you're struggling, if you need help. There's so many services out there, you can pick up the phone and get help. But just while we're talking about prevention and early intervention and areas of health deprivation, the 2024 figures that have been released, 290 people that have lost their lives. We know that the rates continue to be the highest in our most deprived communities. So just if you want to make any comment on that. Thank you.
Well, I've seen the figures as you have earlier, and they're shocking. 30 up on the previous year. All I would say is what officials would say. It's important to take a 3-year average, because the first 2 quarters of this year are more encouraging in terms of the numbers. But every suicide is one too many, and they're all avoidable up to the point where they are actually actioned. And I'm very aware it is more prevalent in areas of deprivation. And I would just assure you that while I'm in this chair with this role, tackling health inequalities will remain my number one desire. And if I could make an appeal to the committee, and it's maybe not for this mandate, it's maybe for next mandate, but there are 3 really sticky issues that we face that we've never really taken a lump out of. Health inequalities measured by healthy living expectations, educational underachievement, which affects the same communities, generation after generation, areas of deprivation, and economic inactivity, which is at 27% of people of working age not in work or seeking work. And they're all interrelated, and health has a role to play in all of them, because healthier children do better at schools. The biggest single reason for people being economically inactive is poor mental and physical health. It needs a whole government approach, and I'm willing to work with the Economy Minister on economic inactivity, with the Education Minister on educational underachievement. As an Assembly and an Executive, we could all work together, and if we did, I'm saying maybe not until next mandate that we see results, but if we commit to that journey, my goodness, what a positive impact we could make on society.
Thank you, Minister.
Earlier, thank you very much. Alan?
Chair, thanks, and thanks, Minister. Minister, we're very brief. I like the MDT model, and I know in speaking to GPs, many of them like it too. Yeah. They see it as taking a bit of pressure off them. They see it as taking a bit of pressure off EDs. I like the idea of being into a facility and being directed onwards under that one roof to another sector of the health service, rather than being directed here, there and everywhere. But obviously the paper here made reference to MDTs commencing in a number of federation areas in the next 5 years, and the full rollout will take around 8 years. Obviously it's a bit of an open goal in terms of taking that bit of pressure off GPs, which we all want to see happening. We know the pressure they're under. It takes a bit of pressure off EDs. Why can that not be ramped up further? Or is that a very stupid question? Are you going to say funding?
Well, I'm going to say funding and workforce, which go together. I mean, I would love to click my fingers, Alan, and say there's MDTs everywhere, because they are perhaps the poster boys of transformation, and there are many good examples in secondary care, the rapid diagnostic centres, the overnight elective care centres, the Lagan Valleys, the Mater hospitals. But actually MDTs have really stood out in terms of their excellence. And every time I mention MDTs, by the way, I also want to acknowledge advanced nurse practitioners in primary care, because they also take a huge amount of pressure off GPs, and actually they were there first. So we tend to forget them because we're so bigging up the MDTs. The rollout is going as fast as it can, but it is dictated by available funds and also the ability to train and attract the workforce. So it's horrible that for 8 years there's going to be an inconsistency.
Just moving then on to EDs, and I'm at the stage now, I don't think any of us in this room can be shocked anymore, but when we seen the image on the front page of a newspaper of a 55-year-old man with stage 4 cancer lying for 50 hours plus on a floor at Altnagalvin, I think all of us found that incredibly heartbreaking. I suppose on the back of that, I thought, whilst we know that the pressures or the bed pressures are driving a lot of that within EDs, but has it been tracked? And this is not a criticism of GPs in any way, because and what I'm about to say is reflective of the pressure that they have, but has it been tracked the number of people who are presenting at EDs that could have been seen in primary care, but they couldn't get access to primary care, they couldn't get an appointment with their GP? Is that a factor that is driving some of the pressures in EDs? And also, are the pathways, the current pathways with the SWA arrangements of transporting patients from SWA up to Altnagalvin, are they another factor that is driving those insane pressures at Altnagalvin?
Well, in terms of Altnagalvin, it is worth recording again, it's the oldest of the type 1 EDs, and it looks it. And when I went up, it was pretty shocking, particularly the toileting facilities. So a tranche of money has been found to do some temporary work with the existing ED, pending the building of the new ED, but that's years, not months away. Does lack of access to GPs play into this? I can't give you empirical evidence of that, but I could tell you, for example, and this is just anecdotal, and you shouldn't be determining health policy on anecdotes, but I was in the Royal and I went up to see the minor injuries, and there were people in there with packed lunches and flasks and their podcasts, and I asked them and they said, no, we didn't go to our GP because I'm not going to spend 140 phone calls to get through. I know coming here means I'm going to be waiting 5, 6, 7, 8 hours, but I've got everything I need and I'm happy to wait. So there has to be an element of it, but whether it is anything like in the top tier of significance of elements, I cannot say to you, and I would be reluctant to almost make that. It could come across as an accusation against GPs, and I'm not doing that. But some people, an unspecified number, are making that personal decision. But
you're absolutely right. It's not a criticism of GPs, and we don't want to go down that road because we all recognise the challenges that they are facing too as well.
At Altnagalvin, you've got the respiratory unit, which is opening extra hours. You've got the minor injuries. We're doing everything we can to find pathways that can avoid ED where possible.
Okay. Thank you. Look, thank you, Minister, and your team. You've been very generous with your time, and we really appreciate that.
It's very important, and thank you for your interest, and particularly can I say thank you for respecting the need, I suppose, to not get into any detail about what's happening with the GPs. I think that's very helpful. I appreciate it.
Good morning. Thank you. Okay, members, there's a good chance that some of the items beyond the next one will be held back to next week, but we're going to go with the next briefing, which is on the new management of violence and aggression in the workforce framework. So can I refer members to papers tab 7 from page 125. That includes a briefing from the department at page 126. I'm just welcome the team in.
Very cold there, isn't it?
Miss Balch is right, he had it. He didn't need to go automatic, he nearly died and he didn't want to.
Okay, so just welcome in no particular order. Seamus Mullan, Director of Performance and Planning, NIAS, John Doherty, Assistant Director of Mental Health within the Western Trust, Brona Shaw, Deputy Director of Nursing, Belfast Trust, John McGall, Director of Mental Health, Southern Trust, and Suzanne Pullins, Interim Chief Executive within the Northern Trust. So these are all very welcome. Apologies for way over time. As you can understand, with the Minister, and that was always going to go over time, so apologies for that. So appreciate your patience. I'm going to hand over to yourselves for opening remarks, and then we'll take questions. Have you worked out? So Suzanne?
Thank you very much for the opportunity to brief the committee today. It's representatives from the Health and Social Care Trust here to provide the oral briefing on the issue of violence and aggression towards staff. Given the operational nature of this issue and the direct experience of trusts and arm's length bodies as employers, it was agreed that the Trust representatives should attend this oral briefing. So the Violence and Aggression in the Workplace HSE framework was developed in collaboration with trusts and trade union colleagues and was launched in December 2023. And it was to guide the prevention, reduction and management of violence and aggression towards staff in the workplace. Each trust acknowledges that staff and those they provide services to have a right to feel safe from threat and violence from others in their care setting and workplace. And given that experience, I've a number of people here with me today, so who you've actually introduced, but we've had a few changes at the last minute, so it might be helpful if I just say who else is here. So you've mentioned Brona Shaw, who's the Deputy Director of Nursing in the Belfast Trust. Instead of John Doherty, we have Donna Keenan, who's Executive Director of Nursing in the Western Trust. We have Jan McGall, who's the Director of Mental Health, and then Seamus Mullan, Director of Planning and Performance, and I'm Suzanne Pullins from the Northern Trust. So the key aim of the briefing is to provide the committee with a comprehensive overview of the operational experience. The framework is underpinned by the health and safety legislation, which places a duty on us, the trusts, to provide a safe and secure environment and support for staff and others. An important step is to undertake the risk assessments in order to support the creation of safer working environments. The framework applies to all health and social care staff, students and volunteers, and is used in conjunction with other relevant local guidance and regional guidance, such as the regional framework on the use of restrictive practices in Northern Ireland and regional operational procedure for the use of seclusion 2021 as appropriate. In the 2023 framework, the MOVA liaison function was introduced in the framework to provide a coordination point for the gathering and monitoring of information relating to all incidents of violence and aggression, and to provide additional support for staff who have been involved in incidents. A key focus is the prevention and reduction of the likelihood of violence and aggression, and I would like to hand over to Jan McGall to talk us through the methods used in mental health.
So when an adult with significant mental health problems can no longer be supported at home, they're usually admitted to inpatient mental health hospital services. These are already highly pressurised and challenging environments, and there can be significant incidences of patient conflict behaviour such as aggression, violence, self-harm, absconding and substance misuse, and then staff containment behaviours which can rely on medication, physical restraint, seclusion and special observation. Violence and aggression incidents on mental health inpatient wards are identified as issues that negatively affect the staff, the patients, the care delivery and the overall safety. Problems of violence and aggression can be exacerbated when caring for someone who has been detained to hospital against their will, where there's a coexisting substance misuse issue, when wards are over-occupied in numbers of patients, and where the environment or a lack of purposeful activity does not promote recovery and minimising restrictive interventions. Incidents of violence and aggression can have poor patient outcomes alongside negative psychological outcomes, physical injuries and reduced job satisfaction for our healthcare staff. On occasion, our patients may display violent and aggressive behaviour in response to fear and their innate need for protection if an interaction or situation ignites a fight or flight response in conditions such as delirium and dementia. The literature would indicate that these patients may experience emotion as their confusion resolves, and this can be associated with embarrassment and post-traumatic stress. So it's really important that we as healthcare providers minimise the impact on both our staff and our patients. There are a range of methods that can be used to minimise, manage and reduce the incidences of violence and aggression on psychiatric wards. These include treating the presenting mental illness, engagement with the patient, increasing observation levels, the provision of medication and safety interventions. On occasion, restrictive practices are necessary for the safety of both our staff and our patients. There's evidence of good practice, such as safe wards, and this is an internationally recognised model of good practice for mental health wards that uses a series of evidence-based interventions to reduce conflict and the need for physical restraint, impacting positively on the safety of our staff and our patients. There are elements of this approach in place across all mental health services in Northern Ireland. It aims to create a safer and more therapeutic environment for patients and staff by focusing on proactive staff engagement, improved communication and specific techniques to manage and de-escalate challenging situations. In the Southern Trust, many of you will be aware, Bluestone Hospital and the Craigavon area hospital site is a multifunctional psychiatric hospital including general adult wards, psychiatric intensive care, an older person's mental health ward, an assessment and treatment unit for dementia and an intellectual disability ward. Bed occupancy in Bluestone, similar to every other psychiatric unit in Northern Ireland, has been above 100% over the last 18 months. And there has been a notable pattern of high acuity of presenting illness, which at times often results in increasing incidences of violence and aggression. We as a management team knew it was important that we did something to support our staff. So with a vision to create a therapeutic and recovery focused mental health inpatient services where our patients received the highest quality of care and where our staff felt supported and safe to do their jobs, we implemented Safe Ward. The key elements are to reduce violence and aggressive and restrictive interventions, and this is achieved through the application of 10 interventions. I'll not go through these all in detail today, but there is a strong focus on the staff team, providing psychological safety for our staff to do their job and to do it well, fostering and maintaining staff morale, emotional regulation through psychological support, supervision, reflection and debrief, which is really important after any incidents of violence and aggression, and also staff appreciation, saying thank you for turning up every day and going forward when others don't. The Southern Trust has promoted this aspect through regular post-incident debriefs, individual and group reflective practice and thinking sessions, Greytex, which is the recognition of staff contribution, and the hosting of staff wellbeing events. Our staff and their wellbeing is central to the way we deliver care. The physical environment, I've already mentioned, is really important in safe wards, and there's evidence that a calm, recovery-focused physical environment can promote recovery but also reduce risks of violence and aggression. To this end, we have created sensory rooms, calm rooms, outdoor green spaces, an outdoor gym and a family visiting garden. Purposeful meaning activity is also really important in trying to reduce violence and aggression directed towards our staff, individuals themselves and others. So promoting a sense of active participation, purposeful use of time and development of hobbies and interests is really key in mental health recovery. The impact on this has been that we have seen a steadying of our violence and aggression levels and a decrease at times. I suppose the numbers are not always reflective of an increase in incidents of violence and aggression, because we know we have been proactively encouraging our staff to report every incident of violence and aggression, and we're seeing that trend hopefully improving, because we know as it stands today there's a large majority of under-reporting. Our staff accept it as part of the job. Our focus is more importantly on lessening the severity of incidences and lessening the impact on both our staff and our patients. So in closing, our staff are saying that the introduction of safe wards allows them a new way to do things, gives them more tools in their toolbox to keep themselves and the patients safe, and our service users are telling us that it's improving the communication, their therapeutic recovery and feeling safe in a relaxed environment. I'll hand back to Suzanne.
Okay. So, as I've said in the introduction, the framework requires us as Trust to have systems in place to reduce the likelihood of violence and aggression, and really focus on risk assessments, staff training and incident reporting. And Jan has already referred to that, and The analysis of the incident reporting is how we learn. It also helps us to put measures in place to help with the reduction in incidents of violence and aggression towards staff. So I'm going to hand over to Seamus Mullan from NIAS, who's going to take us through the NIAS experience.
Thank you, Suzanne. In the first 6 months of 2025-26, NIAS recorded 401 incidents of violence and aggression towards staff. The Trust has recently put a new process in place to make it easier for call handlers working in the NIAS Emergency Operations Centre to log when they're subjected to aggression and or abuse, and this has resulted in an increase in the number of recorded verbal abuse incidents in recent months. This is hugely important, however, as it provides us an opportunity to pre-alert crews who are dispatched to a location where there may have been a history of violence and aggression. NIAS is slightly different from the other trusts. In this regard, specifically our crews will attend to patients in their home or in a public place, where on occasion they may be a lone responder. So in that regard, we provide a number of measures to mitigate harm to staff. We implement body-worn cameras for staff to wear while on shift. We've appointed a violence reduction lead in the Trust, whose role includes raising awareness about the risks and ensuring that appropriate steps are taken following an incident. We provide training to staff on conflict resolution on induction to the organisation, and we have community engagement initiatives as well to raise awareness of the impact of violence and aggression towards staff. And we're also the only ambulance trust in the UK to have peer paid support workers who can liaise with staff in the event of an incident. We recognise that the actual incidence of violence and aggression is likely to be far higher because our work with other UK ambulance trusts suggests that staff tend to underreport, as Jan has referred to. This is an issue that's common across all ambulance services. The latest NHS England staff survey found that just under 25% of staff did not report the most recent incident of physical violence they were subjected to when at work. So the data I presented earlier on is unlikely to represent the true extent of threats faced by NIAS staff. The increasing volume of violence and aggression locally reflects a national picture. The Association of Ambulance Chief Executives found that there were over 22,500 incidents of violence reported by ambulance workers across the UK in 2024-25. This represents an increase of almost 15% to the previous year. We meet on a monthly basis with our colleagues from across the UK and Ireland through the National Ambulance Violence and Security Group. And in fact, we recently in Belfast hosted the annual meeting of NAVSEG and had the opportunity to highlight some of our good practice to other ambulance trusts across the UK and Ireland. Some of the contributory factors, just to give you some information on that. Some of the typical common factors we do detailed analysis of any incident that's reported within the trust. Alcohol and drug consumption. We see alcohol and drugs as a contributory factor in between 40 to 50% of violence and aggression incidents towards staff. The presence of weapons is a trend as well. The number of reported incidents involving a weapon has increased by 14% in the last 5 years. So that represents an increased level of threat to NIAS staff. Service users demonstrating physically aggressive and violent behaviour towards ambulance workers at the scene, we see taken through conveyance and into emergency department as well. We see an increasing number of incidents involving sexual abuse and assault directed towards NIAS staff by service users and bystanders. And we also see a number of patients, again as Jan has said, experiencing acute mental health crisis. Those are some of the trends that we're seeing in the detailed analysis that we carry out within NIAS. So I'll hand over at this stage to Donna.
Thank you. I'm just going to talk about our staff training. So each of our organisations must designate a specific individual with overall responsibility and accountability for ensuring that appropriate training is delivered at both the induction stage and subsequently afterwards. The 6 trusts have had to prioritise their training capacity for substantive staff. Each trust has developed a training delivery programme. However, there are challenges with capacity in the training programmes and the release of staff to the refresher courses. For example, in the Nothern Trust, there is a well-established approach to the safety intervention training in mental health, whereas in the acute setting, there is a cascade training approach delivered by a range of staff from the divisions who are coordinated to deliver that training. based on a risk assessment for the clinical area that the staff are employed in. Can I hand over to Suzanne?
So one of the major areas that we've been working on in the Northern Trust is in relation to the MOVA liaison function, so the Management of Aggression and Violence liaison function. And that's really for people who've been involved in violent incidents or any incident actually. So we've developed a model that I suppose outlines responsibility between the health and safety team and the divisional management teams and local ward areas. So the health and safety team provide a central coordination point for the gathering and monitoring of information and provide a regular review for the senior executive team of all incidents of violence and aggression to board staff and an overview of the staff personal impact assessments so that we can learn from the themes and to inform our decision making in the prevention and management of violence and aggression. We undertake regular reviews of those staff personal impact assessments and documentation, and where appropriate link with the line managers regarding the support of staff that have been involved in serious incidents, which may include the accompanying them, if appropriate, as civil court cases. This support mechanism is best done by their peers and by their managers, and it also then gives them some continuity on the day by day. So we also identify then the relevant incidents through the DayTech system, and then when those are signed off, that the learning is fed into our governance and assurance system. The health and safety team have been building strong relationships with the PSNI because often we have to rely on them responding to us to assist. So I'll hand over to Brona.
So just to summarise what has been said this afternoon to you, for staff and witnesses who are involved in aggressive and violent incidents, they often experience high levels of distress and effects which can last for a considerable period of time. On occasions, patients may display violent and aggressive behaviour in response to fear and their underlying physical and psychological conditions. The 6 trusts acknowledge that this is not part of our job, to be subjected to violence and aggression in the workplace. The MOVA liaison function is, we acknowledge, critical and important to support staff following an incident. 4 of our trusts have supported the introduction of body-worn cameras on a pilot or permanent basis, and the trusts continue to learn from the use of these body-worn cameras. One of the most challenging issues after being involved in an aggressive incident is the requirement for the victim to report the crime to the Police Service of Northern Ireland. Regrettably, trusts are unable to do this on behalf of their staff member. Trusts need to continue to encourage the reporting of incidents to address the current position that we know is there of underreporting. And we continue ongoing collaboration with our statutory partners to increase learning about the root cause of violence of aggression, share best practice in learning and support enforcement of perpetrators. We believe we would benefit from a further public messaging campaign on this important issue. Thank you.
Okay, thank you all. That was very thorough and very useful. I suppose, for the first thing I should say, when this committee got the figures of levels of violence against workers, we were all shocked. I was completely shocked at the figures. It's actually worse just because when you're listening to yourselves giving evidence, you're just saying it's underreported. So the figures themselves are extremely worried, and the fact that they're being underreported are extremely worried. I'm conscious that nobody should be going to their work and feeling that they have to accept violence, threats of violence, intimidation, or whether it's physical or verbal. And that there should be zero tolerance to that. So I think it's important to say that at the outset. So we have this framework. I'm interested to know, because you have all at different points outlined good work that's happening. Is the good work being shared across all the trusts? Is the things that you're being describing that some of you are doing, is that happening? Does it have to happen across all the trusts? Is that part of the framework, that there are specific things that have to happen over and above what individual trusts may or may not be doing individually?
So I'll start off and then others may wish to come in. So there are key elements which we've outlined in the oral briefing, and that particularly is incident reporting, risk assessments of environment. So in my trust, we undertook risk assessments in the acute sector, I suppose, to equate the level of training that staff needed. So we have a general awareness, and it moves up to disengagement and then obviously restraint, which is primarily used in mental health. We have a committee that's led by the Director of Nursing and the Director of HR, and they are overseeing the implementation of the regional framework. So I think from our perspective, it was very well established in mental health. So from an acute hospital perspective, we've started at a different baseline, and therefore that's why we've trained some of our staff who weren't previously involved in delivering training, but in close partnership with the mental health team who have delivered training for many years. So we've been building up our capacity to do training. And as I say, many people feel that they need the highest level of training, but often when you look at their environment and the incidence of violence and aggression, we can actually get them a lower level of training that gives them knowledge. So we're starting from quite a low base level, and there's a training programme today, and today we had 12 places on the training programme, but 8 staff were able to turn up, obviously because of the weather conditions. So it's going to take us some time to get everyone trained within the acute sector that requires training.
Okay, and Brona, you ended by saying you think this issue would benefit from a public awareness campaign. Some of the benefits of this committee in the past and hopefully in the future is that when we get presentations like this, the media will pick up on it and do some of that public awareness on behalf of yourselves. Today, with the Minister being in and with other things that are happening in news, perhaps that won't be the case, but I mean, I would encourage any media that are listening to this to pick up on this issue, because it is something that should be given appropriate focus.
As part of the framework, there were posters developed that said that it was not part of the job, and we've got those posters in our clinical areas and displayed. However, when that was very public in 2023, I believe 2 staff members, they described the experience of having an incident themselves, and you could see that there was a huge focus on it. But I suppose those 2 years have passed now, and we probably have a responsibility to try and increase that again.
Sorry. Going to go around to other members now. Nola?
Thank you very much for the presentation. I had a friend text me when you came in about the very issue, who works in healthcare, telling me make sure you listen and ask questions of this, because I'm relayed an incident to her at work. So it's obviously staff know this is happening, and they are listening to it because it's important to them. And one of the issues that always gets me is, in my constituency office, we don't tolerate violence. We don't tolerate the anger as well, even on the phone calls when people use rude language. But when it comes to healthcare, and I know the answer to this, but just confirming, you always have to give healthcare to everyone who needs it, no matter the way in which you're treated.
And sometimes people present, in distress states, and that comes across as being violent and aggressive because of their condition. So it's about understanding that, and about our staff feeling empowered and able to manage those situations, and we're building a culture within those hotspots, if you like, of looking after one another and being able to support one another when those things happen. We hope that the body-worn camera work will help staff feel more empowered and more in control, and will certainly give them more opportunity to maybe take it further with prosecution, if that's what they want to do. But we're very aware of that. Yeah.
How is the reception being of those wearing it, the uptake in terms of the body cam footage?
So not to preempt the consultation pilot in the Northern Trust, I think our staff felt slightly nervous at the outset of wearing the cameras, but there's been a lot of support within the department, and the feedback is positive. So we will do a full evaluation actually, but there has been an increase in confidence, and as I say, we have supported teams to be able to understand why we're using the cameras and when we should use them. So it was a group of senior nurses in the emergency department. So certainly I hear positive noises about that. Just going back to your question about we always have to provide healthcare, and we do if someone has a clinical condition that needs treatment, and often it's their clinical condition that causes the violence and aggression, and that's the challenge for healthcare workers to be able to differentiate. And that's why we do the risk assessments, and we do some assessments at admission to understand if people have had any periods of confusion, etc. But so that is often the challenge, differentiating between those who are genuinely violent and aggressive according to their clinical condition.
With regards to those people, is there a demographic shift? I know that when I attend A&E and I've ever seen violence, it has been a person who's been drunk. And I just don't know if there is a demographic of people that are routinely violent towards staff. And in terms of the drug and alcohol misuse, there's obviously the issue of addiction there too. And what other steps with that specific group of people can you essentially put in place?
Not seeing a demographic as such. I've already referred we've done deep analysis and continue to do deep analysis of incidents that are reported. So said earlier on, it ranges anywhere from between 40 and 50% of patients that have drugs and alcohol on board at the time. But in terms of an actual demographic, don't really see anything. We do see spikes at certain times of the year. So in around festive activities, public holidays, certain times of the year in Northern Ireland where you would have, St. Patrick's Day, 12th of July, you'll see spikes in around those periods of time, and we'll see corresponding increase in our staff proactively signing out body-worn video at that time of the year. Just going on their experience, but no demographic as such.
And with regards to that 40 to 50%, is there anything that can be done or is done for those people to kind of level out the aggression? I'm asking because I genuinely don't know in terms of the alcohol and drugs.
Well, our staff are trained. On induction, all paramedics, the EMTs will be trained conflict resolution training. So it's about a mixture of risk assessment, training, skill, and dealing with patients as well. So there are other mitigation factors that have been put in place. Body-worn video is one of them. It's not the only one.
Mm-hmm. I'm sure we'd all love to just make them sleep if it wasn't medical risk, but not as easy as that. But it is unfortunate, and it's a difficult one that I myself as a committee member don't know how we have all the answers to it, and hopefully the body-worn footage review and pilot shows us that it's possible.
I guess it's encouraging staff as well, and we've evidence since we've been running the body-worn video programme in NIAS. We've submitted 40 incidents for prosecution to PPS as well. So it's around generating awareness of that among staff and giving them assurance that it's been used for the right reasons, and that it's been taken forward to prosecution as well where we have evidence.
Thank you very much. Thank you.
Okay, thanks, Danny.
Thank you, Chair. Nuala's kind of come in on a few of the questions I was going to ask. I've had a bit of experience of this in my previous life as a nurse, and I know a lot of colleagues that have had very serious incidents, in some cases damage into their careers. Is there a breakdown in where you would see the majority of these incidents occurring, A&Es or any particular types of wards?
I suppose in mental health and learning disability wards you would see higher levels. That could be because there are higher level of incidences just by the population that we're working with, but also because it has been a long and lengthy culture of encouraging reporting. So there will be higher levels. But I suppose the worrying feature is that it is extending across all clinical programmes of care, and our ED departments are becoming increasingly volatile. So we will see it. It is an unfortunate, at times, occasion that you have violence and aggressive tendencies when you're mentally ill. And as I referred to in my oral evidence, the treating of the mental illness, the promotion of mutual respect, we're here to help. That is our first and foremost function. The body-worn videos are active in the Southern Trust and our psychiatric wards. They're switched on at times where our staff feel that it is necessary, and it has been acting as a deterrent to try and help the patient contain their levels of aggression directed to us, and we are seeing that having a positive impact. So I suppose in mental health and learning disabilities we are well trained to instigate the various levels of de-escalation right through to restraint, but cognizant that often it's in the context of the presenting clinical condition which we are required to help and support with.
It's sad that it's got to that level, that you need to do that, but it's interesting to hear that turning on the camera does have an effect.
So de-escalation, I suppose, is helping the patient and the service user be responsible for the entirety of their behaviour. And then it's really important that we do debrief afterwards when the patient is much more settled, to try and prevent it happening again, and to help them understand and help us understand how we can prevent that level of escalation through our therapeutic engagement.
And are those staff supported after violent incidents? How are they supported?
Yeah, so I'll hand over to my colleagues, but in mental health services, yes, we undertake hot and cold debrief, which is also part of the management of violence and aggression policy, where we respond and debrief at the time, and then a few days later talk through with our staff how it felt, and offer support through occupational health or other support mechanisms to help them to continue to care, and that's really important. As you mentioned, sometimes this can have an impact on people's careers, so it's really important that we help staff to process what has happened to them so that they can come back to work the next day.
It is incredibly frightening and causes a lot of stress for people.
Absolutely does, yeah.
So that's why we have the MOVA liaison function as set out in the framework, to support that individual and to make sure that they have someone to talk to. Obviously the line manager and other people within the management team will do referrals to occupational health. We'll make sure that you have adequate psychological support, and we'll keep in touch with you. And basically, if as the victim they then go on to report to the police service the incident that has occurred, then we will continue with them to support them even through that process. And through, in relation to, we've had an incident where it was a worker who was not actually substantively employed within the trust, and the nurse bank provided that support. So we want to reach out to people. We understand that this can actually be career limiting, and has a dreadful impact on your own personal life and well-being. And we really do want to support our staff the best we can. Now, we haven't always got it right, but we're definitely trying to do that support function as best we can. Within the acute sector, and yes, it's a similar pattern in the trust that I work in, that mental health, learning disability would be the highest reporting specialties, but within the acute it is ED and the medical admission wards, and that's certainly where we try to target our support.
Thank you very much. Glad to hear that. And I look forward to hearing the report about the body-worn cameras.
Yes.
It'll be interesting. Thank you.
Thanks. Dan?
Just really to follow on, is there anywhere where there is a more formal assessment of staff views on how they feel, whether they feel they've been supported or not supported, in relation, because it's a very high incident rate, and obviously the Belfast Trust is the highest, but it is the largest, so we might expect more there. But the other trusts are all sitting around the same level as well. So is there, and maybe if you don't have it, that's fine, but if you can just show us where we could access anything where staff have expressed their view on whether they've felt supported or not.
Within the Western Trust we have critical incident stress management, a CHISM session, and it's trained staff where after such an incident we would go and we would meet, there'd be two of us would go and meet with the people who've been involved in the incident, and it gives them an opportunity to go through. It's a very structured approach that we take to listening to them and to the situation that they've been in, and they get a chance to be very open with us of how they felt, and that would include how they actually feel if they're supported by their managers, by the trust as a whole. But it's a very kind of confidential. We don't share that beyond that. We don't take notes at the meeting, but we would have a follow-up session with them then again about 6 weeks later, and that might be one person or it might be a team, and it can be for this, it can be for any critical incident that we have, but it is very much confidential because they have to trust us when they're sharing how they really feel about the incident.
I think that is probably one of the most important things. And just to follow on, do we know if there are staff absences because of this, and does anybody have any detail on that?
Well, from January 23 to now, we've had 73 staff who've been off more than 3 days. So
is that due to?
Yes, that's solely due to the management of violence and aggression. They will be through that.
And is it a similar number in other trusts?
We have had 90 in Belfast.
That's all calls.
470.
That's all calls.
Oh, right, okay.
So our health and safety teams monitor this through their, I'm going to say, radar reporting. If someone is off more than, if they have a major injury or they're over 3 days absent from work. So that will describe the physical, cover that, but it won't cover the emotional, if you understand. So that is a gap for us, but we monitor this through our absence management. So I don't have those figures entirely with me today, but we could get them to you.
That'd be great. Thank you. I just think it is a huge issue, and staff should feel safe going to work, and they should feel supported after an incident. And I just think it's a massive issue. I've seen some of the behaviours in ED, and it is quite scary for people who are sitting in ED watching it, never named staff who have to deal with it. Thank you very much. Thank you.
Thanks, Dan. Alan?
Thanks, Chair. The Chair's right that the media have a part to play in this here, and we're keen to know of some of the injuries that has resulted on the back of some of that physical abuse. My understanding that there are injuries such as people have been burned, choked, knocked out. Is that factual?
We've had staff who've had their eye socket broke, and more severe injuries to abdomen. I mean, it's quite frightening. You come into work and somebody attacks you, and it's not just always the physical. We have a lot of sexual, racial abuse as well, and particularly sometimes for lone workers who are out in the community as well. So we have a lot of physical, but we have a lot of aggression as well that takes an impact on our staff, whether that's in a sexual abuse, sexual assault, or if it's a racial assault as well, and a racial abuse. So it does make staff feel very intimidated, and as Suzanne said, they're actually scared. So we are hoping for the pilots that we are using with the body cams, it gives a wee bit more of that security when we are using them, but it's not acceptable, and that's the message we really want to get across. We come to our work to help people when they're at their most needed, and we show people respect, and it's about how do we get that respect back.
Can I ask a question? While there is zero excuse for this behaviour, but do you feel that long waits within EDs are driving some of this too? Patient frustration?
Yes.
Well, there are some frustrations, there's no doubt. I've attended the emergency department myself and waited a long time with family, and you can see people starting to feel slightly frustrated as time goes on, and you're not getting your usual hydration, and it's a long time to wait. So you can see people becoming more on edge, actually.
No excuse for that.
Well, there are facilities there, and we wouldn't ask or condone any violence towards our staff out of frustration.
Colin?
Thank you, Chair, and thank you for the presentation. And I think we all want to completely rid the system of the violence, because nobody should have to face that in their work. And I know it's taken very seriously amongst politicians as well as another career where frequently you get a lot of abuse as part of the role, and to make sure that it's not normalised. But just in terms of interrogating, it's following on maybe a wee bit from Alan's, and I might have heard reference to it earlier but missed just as it was being delivered, is where violence isn't obviously acceptable, is there a medical condition that can lead to it? So for example, if somebody's diabetic and goes into diabetic whatever they have that can lead them to being violent, obviously the violence is unacceptable in the member of staff, but it maybe puts it into a context whenever it comes to the individual. And I think maybe there was reference somewhere to maybe people with dementia and other things. And I reflect back to many years ago working with young people where sometimes you just had a wee troubled soul and they're lashing out. It's not because they deliberately wanted to harm somebody, it was just that was the way they're manifesting their thoughts, their feelings and what they were processing, versus the person that walked in and just threw a dig at somebody and you went, right, no, that's something that's unacceptable. Is there a way of differentiating those within the figures in terms of that, or is it just, and the context maybe as well for that was, there was reference to you can't refer on to the police on behalf of staff, that they have to make that decision. Is there a case where staff maybe go, I kind of understand why that person did it, so I don't want to report it, and where that contention, maybe how that plays out in terms of support?
Yes.
Sorry, there's
Jan,
loads in that there.
We'll do our best. Jan, in her presentation, referenced those with delirium and dementia, so I'll hand over to you if that's okay.
So in the cases of learning disability, at times mental health issues when you're acutely unwell, psychosis, bipolar disorder, when your reality is not as it would be when you're well, delirium and dementia, there is higher rates of violence and aggression in those incidences, and that is driven by a clinical condition. And I do think that is the challenge for our staff, because they come to work to do a good job and care, and they see the person beyond and behind the violence and aggression. That is not to say that any level of aggression and violence is acceptable, and I suppose that is why the therapeutic engagement with the patient when they are well or when they're better, or an understanding of triggers to prevent is really important for our healthcare staff. There's a clear differentiation then, as you say, for somebody who is assaultative because they're frustrated, or potentially because they're under the influence of substances or alcohol. You see a challenge and a tension in our staff reporting patients that they're caring for. We still do encourage our staff to make reports of violence and aggression, because we see that there's opportunities for learning downstream. So in prevention and the environmental changes in the staff skill and training level to prevent. So whilst some of our staff in mental health learning disability facilities will go on to seek their independent attempts to prosecute perpetrators, it is more they're accepted in the context of the mental state or the behaviour of the patient.
There's no way in those figures that's recorded in a way that it's just everything's recorded just as violence?
It's usually, if you're pulling raw figures, it's usually just the numbers. The DATEX system, which has been referred to as our incident management system, and there is a narrative in and around that would allow some context to be given, but it's not easy to extract that on a population-wide level.
That's my understanding as well, but we can ask when we go back to the people who are able to pull the data out for us.
It's not a way to reduce them. Right? One case is too many in terms of violence, but I suppose it puts it into a context. But I like the bit where you're saying that if it is somebody that is being violent and it may be because of their condition or something that they're suffering from, that it's taken that opportunity for learning to be able to say, well, is there something that we could have done beforehand that may have prevented that, or were there circumstances that led to that, and let's make sure that doesn't happen again. And that's as important as trying to prosecute the people that are just coming in and throwing digs or abuse for the sake of it. So, but that's good work. Thank you very much. Thank you, Chair.
Thanks, Colin. Linda?
Just a very quick point on the issue of those who don't report, and I know there are absolutely massive numbers of cases where staff don't report, and they don't report for some of the reasons that you're talking about, Colin, because they know that the person was violent because of their medical condition, whether it be that they had a psychotic episode, or whether it's addiction, whether it's delirium or anything else, and those staff members, and I think that we have to absolutely acknowledge the work that they do, the efforts that they give, and going in and knowing that you may have to face that on a day and daily basis is not very nice, but they do it because they care. And that's also why they don't report. So is there a way of gathering that data without it going through that formal reporting system? Or is that done? Is that currently done, or is it something that we could look to doing? Because I know, and I actually said, I'm not going to even speak on this because I'm going to end up giving the example, but I know my own mother had her nose broke by a patient, but she said, I'm absolutely, and they wanted her to report to the police, and she said, absolutely not. He didn't mean to do that. And he didn't. She was right, he didn't mean to do it, and he was very, very sorry that he'd done it, and he was distressed that he'd hurt her. But the point is that somewhere it probably needs to be recorded, just to have a better idea for yourselves, for what you're talking about, that learning, and I'm sure, Jan, you see it regularly in Bluestone, where people do not want to report because they know those patients, they know that they've dealt with them for long periods of time and they've never been aggressive, and so they're regularly aggressive, but it's to do with their medical condition. So I'm just wondering, is there a way of capturing that data, or is that done, Suzanne? Do you know?
So not sure that we have a reliable system to do that. I liked the actions that NIAS were taking, in that it was someone who was not directly involved in the incident that was able to record it. It's something I think we could take back and look at. I know, for example, someone who has had an injury such as you've described, and they'll be off work, so through their absence management meetings with their line manager, it'll be clear why they're off. So we need to actually remind those that are doing those meetings to ask the staff, did they report? And that might be the best way that we can just try and close off that loop. But for the ones who have less injury, it's just basically talking to them and asking them to report it. But sometimes you're just so traumatised, particularly if you've been involved in an incident, and you want to get to the end of your shift or go home, and then you think, I'll do it when I come back, and then you realise a few days have passed. So those are the people we have to try and engage with.
Right, I come in as well. In Belfast, we do a staff survey every year, and we added a question around safety this year. So that's an anonymous survey, and we can use that then to triangulate across the reporting figures as well, to see what how many staff are saying that throughout their course of their work they've felt intimidated in some way.
Thank you, Chair. Thank
you
very much.
And NIAS, we would have a similar position as well. We have a number of staff surveys that have gone out. So, staff survey looking at culture within the organisation and looking at how the organisation might move in the future. So the issue of long waits and ambulances did come up on that as well, with staff or patients being frustrated and becoming aggressive. And we've recently carried out a staff survey on sexual assault and sexual abuse with staff as well, with support from the UK Association of Ambulance Chief Executives, and we're getting feedback through that as well, that's an issue for staff.
Yeah. The Western Trust, we're also our culture survey. We'll look at the psychological safety of our staff, and we're about to relaunch it again.
Okay, so thank you all. That has been very useful, and again, very useful but very sobering in terms of the issue that we're covering. So thank you.
Thank you.
Thank you. Thank you.
Okay, members, I'm going to suggest then that any of the rest of the issues we put back to next week, unless anybody has anything urgent that they want to raise. No?
Mr. Chairman, if I could just raise really time management here within the committee. I know you have apologised for the presentation when the Minister was here, but from they stopped their presentation, there was just over 60 minutes available to the committee to ask questions, and 6 members took avail of that time. That's 60 minutes, and 1/3 of the committee, 3 of us, were left at the discretion. The top table could have got up and walked out at 4:30. So with their generosity, they stayed on. And you asked us to be succinct, which I think we all try to be, but it's not really fair that's the way it's going. And I think really the committee maybe all need to have a wee look at ourselves and have a wee bit more self-awareness. It's not rocket science to look at that. If there's 60 minutes available to question the Minister and there's 9 of us, it's not rocket science to work out in your own head how much time you have to spend asking questions. So I think that, I know you've apologised for it, but I think the members too need to help you by being succinct, all of us being succinct at the time, but it's really not fair that in a committee like this, I know we have a scrutiny rule, but we all deserve the same amount of time to exercise that scrutiny rule, and it's not always happening.
Yeah. No, apologies. I mean, in previous occasions when the Minister is and we're time constrained, I do strict to people, and I didn't today, so it is my fault, so apologies. It won't happen again. From now on, when we have time constrained briefings, there will be time constraint. I mean, the one aspect I would say is, and it's an issue that I don't know if we're ever going to get around. I mean, sometimes we have people coming in reading stuff that we have, we've got in our pack that that also restrict from the time that we have. So I mean, there are a couple of issues there, but I take the point.
What I'm really the point I'm making is we can all help you, Mr. Chairman.
Yeah, no, understand that. Anyway, we'll move on. We'll learn from that. So everybody's happy. Then we moved everything that's left on the agenda to next week. So I mean, I just would also just let everybody know next meeting is in the South West Accused Hospital next Thursday at 2 o'clock. We have a full day of business from early in the morning. People should be letting the committee staff know if they're available to attend all that stuff as well. Okay, Dan?
Just in relation to next week, I understand that there is some data that has been prepared by a group called CHKS, which is independent outcomes data. It also includes data on emergency general surgery in relation to the SWA. My understanding is that the Department of Health hold that data, but I think it might be relevant for us to see it before we visit the SWA next week.
Okay, well, we can ask for that. Yep.
Who is that group? CHK?
Oh, they're health. They do health data.
They independently verify the trust data.
Yeah. So that's what they do, and I understand that they have produced outcomes data, and it'd be useful if we could see that independent stuff before next week.
If it wasn't massive, but it might be nice if it's possible, if it's not a huge job, to see if that was in comparison to the information we have from the trust, because the comparison might be interesting.
Yes, it would.
I don't know how easy that might be, but if we're going to get a presentation that's telling us one thing and there's somebody else.
Just another one.
So, am I right, Dan, in that group actually verifies the trust data?
They look at the trust data and they provide an analysis. So it'd be good to have.
Yeah. But in terms of what Colin's asking, it should be straightforward, I would think.
Yes, it should be just so that we understand what somebody with some independence has done in relation to that.
Absolutely, we need all the information. Okay, everybody happy?
Yep.
Thank you.
Committee Room 29. Sound. Committee Room 29. Sound.